Three, two, one. We are live now. We can go ahead.
Good evening, everybody. Myself, Dr. Vishal Dave. I'm medical advisor in Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Synergy 29 webinar on the topic Perfecting the Mid-Trimester Skin ISOC Insights. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal OBGY Society. She is Founder-President of ISOVAP Chapter of Bhopal. She is National Executive Member of ESAR. She is Joint Secretary and Joint Treasurer of MPIAG. She is Coordinator of Foxil Infertility Committee. And she is the convener of present Synergy Series as well as she was the convener of Perfection Series and Symbiosis Series in the past. Over to Dr. Monica Singh.
Thank you so much, Dr. Vishal. Thank you so much. And pranam to all dignitaries present today in Synergy 29. I am especially very thankful and obliged lifelong to PC Mahapatra sir for accepting this invitation of his daughter and being here. Sir, we send highest regards to you from bottom of our heart for coming to the program. एंड आपके दर्शन हो गए सर तो मतलब ऐसा लगता है कि सब कुछ अच्छा ही होगा सर थैंक यू सर to introduce Dr. Purna Chandra Mahapatra is like lighting a candle in front of the sun. But we would just like to say that he is a very much beloved leader of Foxy. Not only a great academician, a father figure, and when Sir speaks in an oration in a Foxy conference or anywhere else in the world, everyone listens because he speaks from the heart. His feelings for obstetrics and gynecology go beyond scientific acumen and skill because he is, I think, working with all his heart and soul and giving happiness to countless couples, countless women. And we can see the passion with which he is working. Sir, I do not want to enumerate the awards, but every award which is possible for obstetricians and gynecologists has gone to you. Sir has also is doing a lot of charitable work. His education foundation and Prachi Institute for Mother and Child Care does a lot of work for the underprivileged women. The mission of life of Sir is that he is born to serve, lives for others. He wants to work till last breath. Teaching is his passion, and he wants to be a man rather than a great man. Namaskar to you, sir. Sir, we are all waiting
Uh,
to listen to you.
well, thank you, Monica, for overestimating this man, a dead president of Foxy and an expiry date professor in obstetric and gynecology for that. Thank you very much for emotionally blackmailing me so that I'm here. At the outset, I must compliment the 29th episode of Synergy. I think the organizing committee, mainly the convener, the two brightest couples in the country, Randhir and Monica, for organizing this beautiful webinar on a very common topic, which is day in and day out essential for clinicians, obstetrics, practicing obstetrics and gynecology for that. And I congratulate, I welcome all the people, starting from the guest of honor to the special guest to the representatives and elite gynecologists from various societies. Sable Badhiya, Chhattisgarhia, all Chhattisgarhia Society, all Orissa Society for the joining hands in this particular webinar for that. I welcome each one of you individually for my behalf, personal behalf, and on behalf of the Synergy for joining this particular webinar. Well, Monica, you are so efficient that you could be able to conglomerate 41 people within this 2 hours of this webinar for that. From the various societies, you have put everybody and involve everybody for that. And I especially congratulate and welcome the brightest speaker, Asa Jain, Dr. Asa Jain was a favorite of mine for the last so many decades, and she will be speaking on a particular important topic of mid-trimester scan perfecting. So the whole agenda will be targeted to particularly a focused program on perfecting the mid-trimester scan. I think that is very important and a very good insight from the ISOP, which is very helpful for day in and day out practitioners for that. I always feel that sonography and endoscopy are the two hands of the obstetricians and gynecologists. If an obstetrician is never complete without the knowledge of sonography, a gynecologist is never complete without the knowledge of endoscopy for that. And therefore, the value of ultrasound in obstetrics is well known to everybody for that. I need not mention about it. But the perfectionist is important. How to do perfectly, that's important for that. And that is a focused attempt, particularly in this seminar, divided into two different parts. The Asa Jain will be focusing on a detailed scan in the mid-trimester, how to do it and whether and what are the different things we have to observe in a case of mid-trimester, because this is a very important period in the pregnancy where mid-trimester scan is really important. It's not a very simple job for that. Lot of skill and knowledge is essential for that. The training is essential for that. And that's why continuous observation of the various things are there. And this is the purpose of doing a webinar, seminar, workshops on this particular aspect of sonography for that. And the second will be by the panel discussion by Vandana. I think I congratulate both of you for this particular webinar comprising of a 2.5 hours duration with almost about 12 panelists and 2 experts in the panel. How to approach, how to do it in a right way for that. And that will be very important for that. And the approach to the mid-trimester scan will be done by Asa Jain. We're eager to listen all your talks and panel discussions and the academic endeavor for that also. And thank you again, Monica, for arranging this particular Synergy 2026 and related to a particular topic so important to the obstetricians for that also. And again, I thank all of you for calling me here as part of this. I'm not a chief guest. I don't consider to be a chief guest. I'm one of them for that. I love the Foxy. I love all of you for that. And particularly for academics, I think as a teacher, it's my passion to be associated with you for that. Thank you very much. And I'm here to listen to everything what you are continuing for the next couple of hours for that. Thank you again, Monica, for joining, for bringing me here and be a part of this important event for that. Thank you.
Thank you, sir. Thank you.
PC sir, we love you, sir. We love you too much.
Thank you.
And thank you for your blessings. So now, with blessings of sir with us, I'm sure this program is going to be super duper success. We will now proceed with a little bit. I wanted to tell about the program. Can I have the initial slide? Initial slide, Dr. Vishal, introductory slide, Synergy 29. Yes, before the program. And there is a black bar which is on your...
in your life and career in Foxy for that.
Sir, thank you, sir. So can I have the slide before this, Vishal? Before this. So the 29th episode of Synergy Academic Club was conceived with the idea of perfecting the mid-trimester scan. Vishal, you're not able to show me the first slide.
Madam, that was the banner actually. Banner, we have not put the banner.
You have removed. So this 29th episode is in association with 4 Chhattisgarh and 7 Odisha Foxy societies. And these societies are, we have got Bhilai, Durg, Bilaspur, Raigad and Raipur from Chhattisgarh. And from Odisha, we have got AOGO. We have got Berhampur, Bhubaneswar, Burla, Khorda, North Odisha OBGY Society and Rourkela. All the presidents and secretaries of these societies joined hands with us, and they were very, very, eager to contribute and take this program forward. I'm thankful to all the presidents and secretaries. I'm also thankful to the Society of Fetal Medicine of Chhattisgarh chapter for having joined hands with us, because this is a dedicated fetal medicine topic. For that, I have to thank the president of SFM Chhattisgarh, Dr. Professor Vinita Singh, and the Secretary of SFM Chhattisgarh, Dr. Asha Jain. This is the 29th episode to be held on 29th of April 2026, that is today. And we are fortunate to have got 3 ICOG points for all the live viewers. Now let us we have already seen the scientific program. I would like to now welcome our guests of honor. Our guests of honor for today are our Vice Presidents of FOXI, Dr. Preeti Kumar Madam and Dr. Anju Soni Ma'am. Dr. Preeti Kumar Ma'am, Vice President FOXI North Zone, as well as the Chairperson of the Safe Motherhood Committee. Go to the previous slide, Vishal. Please go to the previous slide. Madam is the Vice President of FOXI North Zone, the Chairperson of Maternal and Perinatal Committee of CEFOC, as well as the President of Lucknow OBGY Society. She will be joining us in in half an hour or so. And we have with us our guest of honor, Dr. Anju Soni Madam. Madam is the Vice President of FOXI West Zone and the past President of the Indian Menopause Society. We welcome Anju Soni Ma'am. Can I have her CV, please? Dr. Anju Soni Ma'am is a popular and a very well-known figure in FOXI. She is always known for her vibrant attitude towards life, a very colorful personality, a very enthusiastic teacher and leader. Madam has led FOXI from the front. Not only as President IMS, she has been also the Governing Council member of ICOG, and she started a journey in FOXI as the Chairperson of HIV and AIDS Committee of FOXI way back in 22 and 23. Madam has also been the president of Jaipur OBGY Society, the recipient of several awards like IOG Excellence Award, Illuminous Alumni Award by CM of Rajasthan, Chikitsa Vibhushan Award, Mehru Dara Hansotia Award, and the Best Committee of FOXI Award. She is the HOD in the Sony Group of Hospitals.
Thank you, Monica. Thank you so much.
Yes,
I'm humble. I am totally humble.
Madam, we would like the blessings.
Thank you so much. And first of all, I would like to congratulate, good evening, everyone. I would like to congratulate Monica for organizing 29th episode, which is a big achievement in itself. And involving the duos from, Chhattisgarh and this place, Chhattisgarh as well as Odisha, Archana, Anjana, Sangeeta, Gitika, then Monica and Anuradha, Kirti, and Dr. Tribhuvan Sahu sir, and none other than Janmay sir, and with him Dr. Ashok, Dr. Sangmitra, Dr. Indra, Dr. Sanjeev, Dr. Tapsi, and other societies of Odisha like Dr. Basant, Dr. Nehari, Dr. Ojaswini, Dr. Lima, Dr. Anup, Dr. Arun, Dr. Sudharani, Dr. Sujata, and all other society people from it, Dr. Vinita Sang and dear Asha. I'm really, I feel so good that all of you have joined today for this very, very important program, and I'm feeling privileged to join with all of you as one of the friends. And it is a wonderful academic collaboration with multiple FOXI society. Truly reflects the spirit of shared for learning and collective growth. And today's topic is also very, very good. Perfecting the midlife scan. I think it is extremely significant in our clinical practice. And this scan is not just a routine step. It is a critical window. I always feel that opening a window at right time is the most important, where timely detection, precision, interpretation, and change in outcome for both mother and baby are there. And I sincerely appreciate that organizing team has done a great job by collecting all of them, and this program will be very practical, focused, and clinically relevant. And I'm sure that today's discussion will enrich our knowledge and further strengthen our commitment to delivering the best care for our patients. And once again, wishing the entire team a great success and an impactful session. Thank you very much for inviting me, and best wishes to you, Monica, for all your future endeavors.
Thank you. Thank you so
So
much.
you
ma'am.
will do a great, the way you have been doing, you'll do great in future also.
Thank you. Thank you so
Congratulations
much.
and best wishes.
Thank you for your blessings, madam. And we would really love it if you could stay on in the program and enjoy the program. But in case any dignitary or audience has to leave the program in between, this webinar is totally recorded completely on YouTube, and we will be providing a link with the help of which you can watch this program later in the comfort of your home. And this is actually the objective of webinars. People often ask me, why do you do these educational activities? There are so many physical conferences. But madam and sirs, you would agree nowadays the attendance in physical conferences is sometimes very unpredictable. And very many times a very good speaker like Dr. Asha Jain, Dr. Anju ma'am, Vanna ma'am, they are speaking in the hall, but several faculty are not able to reach at the same time. Some are arriving, some are departing, and there's a lot of stress of travel. And of course, the attendance is low. But in a webinar, I feel that if the person is
Absolutely, absolutely. And you have roped in the best faculty, the apt faculty, I must say, and I must congratulate the faculties also for being here today. I'm
Okay.
sure the discussion will be really, really enriching for each and every one of us.
Thank you, Anju ma'am, for your kind words. Now I would like to invite our guest of honor, Dr. Janmejay Mohapatra sir. Let us join hands together to applause and greet Dr. Janmejay Mohapatra, the past Vice President of FOXI, as well as President AOGO and SOGO. Professor Dr. Janmejay Mohapatra is the professor and head Department of Gynec Oncology at AH Postgraduate Institute of Cancer at Cuttack. Sir has led FOXI as a leader and is currently the president of the All Odisha OBGY Societies 26 to 27. Sir is also very active in IMA, being the president-elect of IMA Odisha State Branch. He has held various posts in FOXI in the past and was the chairperson of the Clinical Research Committee of FOXI in 2013 to 15. Sir is the recipient of several awards, as well as has organized wonderful conferences all over Odisha and at the national level. He is the recipient of IMA national level awards for dedicated
Thank you, Monica.
with numerous publications. So we are honored to have you with us, and so we would like to have words of blessings from you, sir.
Thank you, Monica, for your kind introduction. Good evening, everybody. Respected chief guest of this webinar, my guru, mentor, and teacher par excellence, and Professor Emeritus OUHS, past President FOXI PC Mahapatra sir. Guest of honor, my elder brother, Dr. Tushar Kar, past chairperson ICOG, Dr. Bhagya Dr. Anju Soni, Dr. Priti Kumar, and Dr. Rajat, and our president and secretaries of all the societies of Chhattisgarh, OBG and Odisha OBG societies. Special guest Dr. Seema, Dr. Munjal, Dr. Tripti Vansal, convener Dr. Monica Singh and Dr. Randir Singh, all the presidents and secretaries of officers of Odisha and Chhattisgarh, and societies of fetal medicine of Chhattisgarh, all the chairpersons, speakers, experts, moderators, and panelists of the panel, my seniors, teachers, colleagues, and friends. First of all, I am congratulating Dr. Monica and Dr. Randir Singh for organizing today's webinar, the 29th episode of Synergy, with 4 obstetrics and gynec societies of Chhattisgarh and 7 societies of Odisha, and also fetal medicine chapter of Chhattisgarh. And the theme and topic is perfecting the mid-trimester scan ISHG insights. I think today's talk and panel will benefit our members in their day-to-day practice. I again welcome you all to this very important and informative webinar, where we will learn a lot from this webinar, which will help us to change our practice and ultimately translate to good clinical practice. Again, thanks to Dr. Monica and Dr. Ranjit Singh for inviting me to this webinar. All the best wishes to Dr. Monica for Chairperson Election 2026 for Pakshi Infertility Committee. Thank you all. Long live Pakshi.
Thank you. Thank you so much, sir, for your blessings. And we would appreciate if you could stay on and enjoy the program, sir. And now I would like to invite.
I will remain.
Ji, sir. We would like to honor and greet our guest of honor, Professor Dr. Tushar Karsar. Sir is with us. Sir has led ICOG as chairperson in the years 2019 to 20. Sir has also been the vice president of FOXI in 2010 to 11 and the president of AOGO from 20 to 23. He is a keen laparoscopic surgeon, professor and unit head at the Department of OBGY at SCB Medical College, Cuttack. Awarded FRCOG by the Royal College of Obstetricians and Gynecologists, has been a very active Foxian as well as in ICOG. We know he has been chairperson. He is extensively involved in academic activities, being the national corresponding editor of Jogi, as well as
Okay, Monica, okay. Thank you so much.
So we would also like to mention that you have received a whole list of awards from the Odisha state, and you are one of the most accomplished, medical persons in Odisha, sir. So we are honored to have you amongst us.
Thank you, Monica. At the outset, I must congratulate Monica and Rambir for this great work, that is academic work, that is 29th episode of Synergy, which you have been carrying out for a long time. You see, respected Purna sir, all the dignitaries like guest of honor Preeti, Anju, Janmanjay, Bhagya, Rajat Rai, special guests, all the chairpersons, experts, speakers, how many people you have brought? So this is a true amalgamation of academic and social. All the societies of Odisha, all the societies of Chhattisgarh, what is your capability? Really, I am astonished. I am really so much happy that you are capable, true leader. That within a short time you could all invite personally as well as also by phone and by social media. So it's a great work. So I must congratulate for that single-handedly to both of you. But here in the 29th episode, today you have selected one of the best topic, and you have also included that fetal medicine of the Chhattisgarh. That is also another, arrow. And the topic, the perfecting the mid-trimester scan. Every one of us almost doing ultrasound. But how many are perfectionists? You ask for me. I am sending almost few cases to the radiologist or so-called fetal medicine specialist for the perfect or the final approval of the result. So therefore, to bring it back, you have done the right thing. By this discussion today, you have also brought the very expert, sonologists, gynec sonologists like Asa, Bandana, and the topics are also very nice for a practitioner. I hope all the participants can be benefited by this discussion today, that is the perfecting the mid-trimester scan. But again, I thanks especially our Purna sir as the chief guest. We could see in the same style, same place, and almost in the social media like this. And Monica, you have brought almost all same wavelength people together today. And I hope it will be very much useful for all the practitioners. Thank you very much, and best for this today's synergy on perfecting the mid-trimester scan. Thank you very much.
Thank you. Thank you so much, sir. And you have really brought out a very important message that if we want to achieve something or, want to do something, it is possible. It is possible. Anything is possible if you have the will and you have friends like all of you, sir, who never say, at least I never get a no from any friend, sir. So I'm blessed.
So nice.
I'm blessed to have seniors and mentors like you, sir. And now, with permission of Tushar sir, I would like to now welcome Bhagyalakshmi Naik, madam. Dr. Bhagyalakshmi Naik a very, very dear teacher to all of us because Madam has been a speaker in earlier Synergy programs. We have had focus programs on gynec oncology in the past, on breast cancer.
Monica,
Yes, Madam. So,
I'm
Madam,
just scrubbing for a case, okay? So many,
yes,
many best wishes for your webinar and best wishes for your future endeavors.
Gigi, thank you so much, ma'am, for being there. Thank you so much, ma'am.
Thank you, Monica. And I think it's really, you are a true Foxian because you have got so many people along with you in this webinar. I think it's kudos to you. Thank you so much. Thank you.
Thank you, Bhagyalakshmi ma'am. And we will be talking to you shortly again for our next program. Now, I would like to welcome our guest of honor, a very favorite dignitary from Odisha, Rajat sir. I must say that whenever my initial endeavors and work in Foxy and ICOG, I have got a lot of support from Dr. Rajat Ray sir. We have had many conversations. Sir has given me important way forward, how to proceed the academic activities, and I'll be always obliged to Dr. Rajat Ray sir for that. Sir is the president of IFUMB, that is the Indian Federation of Ultrasound in Medicine and Biology. So I think he will be really happy with the topic we have chosen today. He's professor in HOD of obstetrics gynecology at High Tech Medical College, Rourkela, as well as the National Dean of the Indian College of Medical Ultrasound. Honorary Professor, IMA Headquarters, New Delhi, as well as the State President of IMA Odisha State in 2022. Sir held the post of VP of Foxy in 2018 and is executive member of various.
Thank you, Dr. Monica.
Sir, we would
Thank
have
you.
loved to
Thank
have.
you for the kind introduction.
Ji.
Respected Chief Guest, Purna sir, all the dignitaries, seniors, and dear friends. I must thank Dr. Monica and Dr. Andir for inviting me and holding this continuously, regularly, these webinars, which is upgrading the knowledge of common delegates. And this topic is especially very close to my heart because I want that all the obstetricians should be able to do anomaly scan. It is not that difficult. If you go step by step, which will be discussed today only, you can follow. We are all doing ultrasounds, but we are afraid of doing an anomaly scan. So after you go through the webinar, I think most of will be confident of doing an anomaly scan rather than referring to other specialists. Thank you, Dr. Monica, and thank you. I also wish you all the best for your all the future endeavors. Thank you, Dr. Monica.
Thank you, Rajat sir. Thank you for being there and for hand holding us. Now I would like to come to our special guests. I think Seema madam was having puja at home. Is she still there, Purva? Madam is there? I think we will welcome her after some time. We would like to welcome our very, very dear Dr. Munjal Pandya. How can we not, be happy when Munjal is around? I think you are a bundle of happiness, Dr. Munjal.
Thank you, ma'am. Thank you so much,
You
ma'am.
are the youngest president of Ahmedabad cannot do. He is a sportsman, he is a singer, he is a writer, he has two beautiful daughters, he's a true blue Foxian, and he is a great, great person. So stage is all yours, Munjal.
Thank you so much, ma'am. First of all, I would like to congratulate you for your endeavor and your commitment towards not just academics, but spreading the word in a very, very impactful and effective manner, ma'am. And second of all, everybody say the one most amazing thing, gathering so many faculties and making this particular platform and experience sharing with all of the viewers is such an innovative and amazing step. It's not always about when we talk about webinars, we would always go ahead with whom we can oblige on, but your view is always unique and dedicated to just academics being the core, and that's how I think you could facilitate keeping all of them with their expert views on same platform. So I congratulate you for your innovative and unique style of arranging this webinars. And I'm really, really sure that viewers of all the 11 societies of Foxy, that is Bhilai, Bilaspur, Raigad, Raipur, Odisha, Behrampur, Bhubaneswar, Burla, Khorda, and North Odisha and Rourkela. All of them are going to get benefited along with all the viewers with whom the flyer has reached already. And you are a person, I haven't seen you as somebody who is a Foxian. I have, been inspired from your your nature, which is very, very kind. Meeting you is always something which is filled with one particular thing, and all of us would agree. You have, a beautiful smile, which makes the other person smile. And that's the amazing thing that a person or human can have. So you inspire not only, with your academics or your skills or knowledge, but you inspire us to become a better human who can spread positivity, radiate the smile and anything and everything that is good within us. So I'm really sure that you are a perfect example of how a human can be, irrespective of any of the agendas. And that's why I'm really, really sure that you are going to succeed in all of your endeavors, Foxy, not just for your benefit, but for the benefits of all the Foxians. So many, many congratulations once again, and best wishes with everything, ma'am. And we'll be here listening to experts and their views throughout the webinar. Thank you, ma'am.
Thank you, Munjani. You have really, blown me over. Thank you so much. I don't even deserve 1% of what you've said, but thank you all the same, and thank you for being my friend. I would also now like to put food before you a very dear friend of mine, Tripti. So Tripti Bansal is my very close to my heart. Her daughter is also very close to my heart. She is a silent worker, working in a very, very busy hospital with her husband's practice.
Thank you so
And,
much.
and she has a very beautiful daughter, and Palak is a literally dynamite. She is dynamite. During residency, Palak Bansal won a 1 lakh Foxy Award for her paper on, I think, RH isoimmunization. So I follow Palak. I'm a total fan of Palak. And because of Palak, I'm also a fan of Tripti. So
Thank you,
would like to, both of you.
thank you so much, Dr. Monica ji. And it's a pleasure to be part of this academic symposium and to share this platform with such a respected expert like God of our gynae, Dr. Mahapatra sir. And I sincerely thank you to you, Dr. Monica, to inviting me to this Synergy Symposium of the Odisha and Chhattisgarh societies. And I also thank Lucknow Obs and Gynae Society for including me on this academic platform. Today's topic, perfecting the mid-trimester scan, is highly relevant to all of us in our clinical practice. A good anomaly scan is not just about finding the abnormalities, but it is about being systematic, accurate, and clinically meaningful. When we do basics well, if our basics are well, we improve our diagnosis, counseling, and pregnancy outcome. I am sure today's discussion will be enriching all of us, and I would like to thank from bottom of my heart to Dr. Randhir Singh also, because मोनिका जी से मिलने से पहले मेरी डॉक्टर रणधीर से मुलाकात हुई थी. Thank you all of us. Thank you.
Thank you, Tripti. Thank you so much for being there and for supporting me in all my activities.
And I second Dr. Munjal ki your beautiful smile is viral.
Thank you, Tripti. Thank you so much. And now, before we proceed towards our societies, I would like to invite Lakshmi Madam. Lakshmi Madam is like my elder sister. Madam is always there with guiding hand. And I think she has got the 1,000-word smile. If we talk of smiles, nobody can go ahead of Lakshmi Madam. So Lakshmi Ma'am, the past chair of ICOG, currently heading AOFOG. Madam, the stage is all yours.
Thank you, Monica, for that special privilege. And I'm really delighted to be part of this 29th episode of your Synergy web series with Chhattisgarh and Odisha societies. As PC sir said, it is commendable that you have really gathered so many societies, presidents, secretaries with you today. And today's focus on correct approach to the mid-trimester scan is extremely relevant, as this scan is pivotal, is very important in early detection of anomalies and guiding the optimal fetal outcomes. So I am sure this will be a really insightful and useful webinar. And Monica, wishing you the very best for your upcoming elections. May you continue to lead the same vision and excellence. And I really echo and agree with whatever Munjal has said about you. I am not going to repeat that. I am also a fan of yours, your kind nature, your smile. You are really a friend in need, I will say. I'm really blessed to have you in my life as a friend. Thank you so much.
Thank you. Thank you. We are blessed, Lakshmi ma'am. Thank you for your words and thank you for your जो साथ आप हमारे को देते हैं, madam. Thank you for that. And now we would like to invite our societies. See, this program
Ma'am,
is because...
Seema ma'am is here with us.
Oh, Seema madam is here. So Seema ma'am, the stage is all yours. Can I have CV of Seema madam? Vishal? Dr. Professor Seema Mehrotra is well known as Secretary of Lucknow OBGY Society and a professor, a beloved professor of students in KGMU Lucknow. Now, to get admission in KGMU Lucknow is a task in itself. It can be called the AIMS of UP. And Madam is a teacher there with several research and publications to her credit. Madam is very well known for the highly successful Art of Birthing Conclave, which just took place in Lucknow. And I don't think we saw her sitting even for a single second. She was all around. She was taking care of multiple dignitaries. She was there last minute till the valedictory. And everybody said that she's a silent hard worker. Madam, we are so obliged to have you amongst us. And we would like to have words of blessings from you, Seema ma'am.
Thank you, Dr. Monica. Thank you for having me here today. And at the outset, I extend my respectful regard to our Honorable Chief Guest, Dr. P.C. Mahapatra, sir, whose energy really inspires us all. And my regard to our esteemed Foxy leaders who have joined today, Dr. Preeti ma'am, Dr. Anju Soni ma'am, Dr. Tushar Kar, Dr. Mahapatra, Dr. Rajat Ray, Dr. Bhagilakshmi Nayak ma'am, Dr. Lakshmi Shrikande ma'am. And my heartfelt congratulations to you, Dr. Monica, for organizing this excellent webinar on obstetric ultrasound by bringing these multiple societies together. It's really commendable. And such platforms are extremely valuable, especially for postgraduate students. And we know that today learning ultrasound, obstetric ultrasound is truly the need of the hour, and it is an essential skill for every obstetrician. And personally, I would say that Dr. Monica is a very gentle and a very humble person, and she's doing remarkable work in infertility and is a well-known, recognized name in this field. And as she stands for the post of chairperson of the Infertility Committee, FOXY, I wish you, Dr. Monica, all the very best for your upcoming elections. Thank you so much for having me here today.
Thank you, Seema ma'am. Despite your busy schedule and rushing home from college, you have joined us. Dr. Preeti Kumar ma'am also. I think she will join us shortly.
Yes,
Now
yes,
we
yes,
should run through our societies and give thanks to presidents and secretaries. And I think all of us they deserve to be known to everyone. The various beautiful societies of Chhattisgarh and Odisha. So let us start. The Chhattisgarh OBGY societies, we give thanks to our dignitaries from all the 4 societies. Bhilai Durg OBGY Society works together as one, though they are different towns, headed by President Dr. Archana Chauhan Madam and the Secretary Dr. Anjana Chaudhary. We welcome both of them. Bilaspur OBGY Society, headed by President Dr. Sangeeta Sharma Madam and Secretary Dr. Geetika Sharma. Geetika Sharma has been there in our previous programs also. Next, we have the Raigad OBGY Society. This is a new addition to Chhattisgarh under the dynamic presidentship of Dr. Tribhuvan Sahu sir and Secretary Dr. Kirti Nanda. Next, we have the largest society of Chhattisgarh, that is the capital of Chhattisgarh and Raipur OBGY Society, headed by Dr. Monica Pathak Madam and Secretary Dr. Anuradha Chaudhary. We welcome both of them and we thank the whole of Chhattisgarh for giving us opportunity to host this program along with them. Next, we come to the Odisha societies. Odisha state has got 7 societies. Number 1, we have the Association of Obstetricians and Gynecologists of Odisha, AOGO, headed by our past VP Foxy, Professor Dr. Janmejay Mohapatra sir. Thank you, sir. We have Secretary Dr. Ashok Kumar Padi sir from AOGO. Next, we have the Berhampur OBGY Society, headed by President Dr. Sangamitra Mohapatra Madam and Secretary Dr. Indira Palo Ma'am We all know Indra Palu ma'am is, well-known Foxian working in Berhampur since a long time, very helpful, and she was instrumental in framing this program. Thank you, madam. Next, we would like to welcome and felicitate the Bhubaneswar OBGY Society, headed by President Dr. Sanjeev R. Nayak, sir, and Secretary Dr. Tapashi Patti, ma'am. Thank you, madam, and thank you, sir. Burla OBGY Society, headed by the dynamic President Dr. Ojaswini Patel, madam, who is also the Professor cum Project Officer, PPC Department of OBGY at Vimsar, Burla, and her able Secretary, Dr. Leena Baru, ma'am. Thank you so much to both of you. Khorda OBGY Society, headed by Dr. Basant Kumar Pati, sir, and his able secretary, Dr. Narahari Agasti. We met each other at the managing committee meeting at Chennai recently. Thank you, Dr. Agasti, for being there. The North Odisha OBGY Society, headed by President Dr. Anup Kumar Ghosh, sir, who is also the retired additional director of health and family welfare at Odisha, with more than 4 decades of working in OBGY field. His secretary is Dr. Arun Kumar Singh, again a very dear friend and ISAR member. He is a dedicated IVF specialist working at Pratiksha Fertility IVF Clinic, Balasore. At the same time, he has agreed to participate in the fetal medicine panel. So that shows how much of passion for academics Dr. Arun has. Thank you, Dr. Arun. We also have Rourkela OBGY Society, headed by President Dr. Sudha Rani Pradhan, ma'am, and Secretary Dr. Sujata Kumari, madam. So that brings us to our last collaborating body, that is the Society of Fetal Medicine, Chhattisgarh chapter, headed by President and Professor AIIMS Raipur, Dr. Vinita Singh. We thank Dr. Vinita Singh for her graciousness in granting us permission to hold this program with SFM Chhattisgarh, and her able secretary and our keynote speaker, Dr. Asha Jain, who is also the chairperson of the Food and Drugs Medico-Surgical Equipment Committee of FOXI, and a very, very able leader. Thank you so much, everyone, for participating with us and collaborating with us. And now let us proceed to our academic program with the help of, you've already met my co-convener, Dr. Randhir. He is the backbone of this program, as well as we have got 2 beautiful coordinators who have been in touch with you. Dr. Purva Bhatkur, Associate Professor at Gandhi Medical College, the largest tertiary medical college of Bhopal, and Dr. Virul Shivastav, who is working as the center head and infertility specialist at New Hope IVF Fertility Center. So all our ideas regarding fertility medicine and are given by Virul, and our obstetrics gynae is guided by Purva. So these 2, I cannot work without them. So now I request Dr. Virul to start the panel. Thank you so much.
Thank you, Monica ma'am. Good evening, all the respected faculties. Now we are proceeding with our session, which is the panel discussion on the topic, how to do the right scan the right way. For that, we have very senior faculties with us. For the moderator, we have Dr. Vandana Bansal ma'am. And for experts, we have Dr. Sujit Konkar sir and Dr. Smita Dingley ma'am. Next slide. First, I would like to introduce Dr. Vandana Bansal ma'am. Ma'am is the additional professor of Gynec and head of ultrasound department at Vadia, Mumbai, and also director at Surya Fetal Medicine Center, Bhopal, Mumbai. She is also first postdoctoral fellow of National Board in India, qualified in high-risk pregnancy and perinatology. Ma'am has 28 years of experience in obs and gynec, including 23 years in fetal medicine. Ma'am is MUHS approved faculty for fellowship program in fetal medicine and MD. And she also has Springer Best Publication Award for 22 and 23. We welcome you, ma'am.
Thank you.
Thank you. Next, we have Dr. Sujit S. Konkar, sir. Sir is a alumnus of GMC Aurangabad, and he is a fetal medicine consultant. Sir is chairperson of Genetic and Fetal Medicine Committee, FOXI 26 and 28. And sir is also a vice president, Society of Fetal Medicine, Marathwada chapter. We welcome you, sir. Next, we have Dr. Smita Dingley, ma'am. Ma'am is a fetal medicine specialist from Bhopal. Ma'am is FMF certified for NT scan and anomaly scan, and also for invasive procedure. She is FOXI certified trainer for ultrasound and obstetrics, faculty for fetal and gynec imaging. We welcome you, ma'am. Now I would like 2 series of panelists in alphabetical order. First, we have Dr. Aditi Rathore, ma'am. Ma'am is a consultant at Rathore Nursing Home, Jaora, secretary at Ratlam Society. We welcome you, ma'am. Next, we have Dr. Anjana Chaudhary, ma'am. Ma'am is a secretary at Bilai Durg Organic Society. We welcome you, ma'am. Next, we have Dr. Anuradha Chaudhary Tibrawal, ma'am. She's a secretary at Raipur Organic Society. We welcome you, ma'am. Next, we have Dr. Arun Kumar Singh, sir. Sir is a director at Pratiksha Fertility and IVF Clinic, Balasore. We welcome you, sir. Next, we have Dr. Kitika Sharma, ma'am. She's a secretary at Bilaspur Organic Society. We welcome you, ma'am. Next, we have Dr. Kirti Nanda, ma'am. Ma'am is a consultant at Rajpriya Hospital, Raigad. We welcome you, ma'am. Next, we have Dr. Monica Pathak, ma'am. She's a president at Raipur Organic Society. We welcome you, ma'am. Next, we have Dr. Narari Agasti, sir, secretary at Korda Organic Society. We welcome you, sir. Next, we have Dr. Neha Saraf, ma'am. Ma'am is a consultant at Ankur Hospital, Ratlam. We welcome you, ma'am.
Thank you so much, Dr. Virat.
Welcome, ma'am. Next, we have Dr. Nidhi Jain, ma'am. Ma'am is a private practitioner at Sagar and also secretary at Sagar Organic Society. We welcome you, ma'am. Next, we have Dr. Palak Bansal, ma'am. She's a consultant gynecologist at Lucknow. We welcome you, ma'am. Lastly, we have Dr. Rekha Singhal, ma'am. She's a secretary at Riva Organic Society. We welcome you, ma'am. Now, I request all the moderators and experts to continue further discussion regarding the panel. Thank you.
My personal warm welcome to Vanna Bansal ma'am and both experts, Dr. Sujit and Dr. Smita. Thank you so much.
Thank you.
Ma'am, please share your slides.
Thank you, Monica, for such a good program you have charted out. So I will share my screen. And so, Monica, I think this topic is so good that you took through. And I hope my screen is seen.
Yes, ma'am.
1 second. Yeah. Can you see my slides and can hear me also, Monica and Virud?
Yes, madam. Yes.
So shall we start with our panel?
Yes, ma'am.
So this is a very interesting panel on mid-trimester anomaly scan. And basically, first we had a lecture on how to do the scan. And now what I'm going to do first is a panel on the same thing. So we are actually going to look at when we have an anomaly, what do we do about it? So have we missed it in an anomaly scan, or have we not been able to pick it up, or whether it evolved later on? And if we are in that problem, then what do we do? How do I solve our troubleshooting? So this topic was very interesting, Monica. You gave me how to do the right scan the right way, and I added to it, how do I troubleshoot, solve the problems in the troubleshooting? And for this, we have a beautiful panel. And with that, we have two experts, Dr. Sujit, my friend, and Dr. Smita also, who are going to help us through this panel, because they are going to be a little difficult cases. I've tried to start off simple and then we go ahead with the cases that we have. So we all know that our guidelines by ISWOG are on the first trimester screening, the second trimester screening, and also now with the third trimester screening. And all of them talk about a universal screening for anomalies. So what we are going to talk about now is this 18 to 24 week scan, which is our the most important scan that we have. The first trimester does help us, but it is not complete, and we still need to do this second trimester, mid-trimester scan. And this is the basic requirements that they are, and we need to fulfill all of them. So the problem is, once we do this scan, are we able to pick up everything, or is there something that we get missed, or we pick it up later on? And that is our panel going to be on. So for this, we have our good obstetricians and fetal medicine with us. And the pediatricians we will call in if required wherever. So we start with our first case, and the basics of this panel is going to be, when I see an anomaly on a second trimester, or whenever we do, we want to first establish the diagnosis, find out whether it is isolated or associated, then look for IUGR if there is. Then does it require a genetic testing or an infection evaluation? Is it lethal or highly morbid, which is not compatible with life, needs a termination, or if it is something which can be taken care of, then where do I deliver them, how I deliver them, when I deliver them, and if so, then what is the recurrence in the next pregnancy. So all our cases, I have 5 cases, and I have about all the panelists, we will mix the panelists one by one on each of the cases. So for the first set of case is a brain abnormality. So for that, I will want Dr. Aditi and Dr. Monica to be with me. And Dr. Smita, you can be our help wherever we want as an expert for this.
Sure.
Our first case, we know in our ISWA guideline, we need to look at the size, shape, density. We have one transthalamic plane which needs to be seen, a transventricular plane which needs to be seen, and a transcerebellar plane which needs to be done. So if I look at my own data, in about 2 years, we had 174 CNS anomalies which were picked up. So there is almost a 15% association among all anomalies of only CNS abnormalities. So maybe Dr. Aditi can start with, how do you measure the lateral ventricles, and what do you call them as significant? Dr. Aditi or Dr. Monica can take it. Do we have them on the panel at the moment?
Patrick is not there, and Aditi, are you there?
Maybe anyone can.
Okay.
Maybe anyone can take it. Who is
Dr. Geetika, you are there? Kirti, Geetika.
Yes, ma'am, I'm there, Dr. Geetika.
I can see Dr. Neha.
Neha is also there. Neha is there. Yeah. So any one of you, please.
Yes. Anyone can take it.
In a axial, transaxial plane.
I'm sorry, ma'am.
Yeah,
the lateral ventricles.
Here,
And normal value should be less than 10 millimeters. 10 mm, and it has to be measured at the in the atrium of the lateral ventricle, inner to inner wall, the measurement.
Yes. So basically the guideline says that you measure it inner to inner, as you said, and at the level of the glomus, but basically wherever you have this parieto-occipital sulcus is where you measure the ventricle and anytime, as you said, more than 10 millimeter is significant for calling it as ventriculomegaly. So I think Aditi is back with us. So Aditi, you can take it forward from here. When will you call it as mild and when will you call it as severe ventriculomegaly? Aditi,
Good evening, ma'am. Thank you. Yes,
Dr.
ma'am, I'm
Aditi?
here. Thank you for involving me in the panel. Ma'am, actually, by the guidelines and so guidelines, up to 12 mm is considered as mild, and from 13 to 15 mm is considered as moderate, and more than 15 mm is considered as severe.
So yes, as you said, it can be mild, moderate, and severe. And also some of the guidelines talk about mild and severe only.
Severe.
Till 15, they take it as mild, and more than 15 as severe. So yeah. So we have this case which was kind of missed in our mid-trimester scan. So I take you through the first case. And again, Aditi, you can be there. Smita, you can help us in the assessment of the disorder also. So this is a 32 years old primi gravida. She was a very highly educated, rich couple who came at 33 weeks to us with this kind of a ventricle. The size of the ventricle is 22 millimeters. So Dr. Aditi, when you as an obstetrician get a patient at 33 weeks with such a big ventricle, how do you take it? And how will you respond to this report?
You'll have to unmute yourself,
Ma'am, you have to
Dr. Aditi.
unmute yourself.
Yeah. So, ma'am, actually, she came at 33 weeks. So, obviously, as per our rule, we cannot terminate her straight away. We have to first counsel her. First and foremost, we have to assess the diagnosis. So, in this case, I would like to have a second opinion of a fetal medicine expert in my case, वैसे. But in 33 weeks, I would advise her to get an MRI brain first.
Yes, you're right. Because, yes, so correct, as you said, if you see a ventriculomegaly, I want to know more about it. So I will refer her to a fetal medicine specialist to find out what is the cause for this ventriculomegaly. So Smita, the patient has been referred to you. You are the expert here also in this. So how will you take it forward? How will you try to find out the etiology for this ventriculomegaly? Smita.
Definitely, if at
Hi, Dr.
33 weeks
Smita,
I'm finding
you
this,
can.
I would like to see more of the brain. And because by 33 weeks, I should have the brain, different brain parts quite good developed. So I'll go for a fetal neurosonogram first. And I'll try to find what is the state of both the ventricles, what is the complete ventricular system, the third ventricle, what's the state of fourth ventricle, how is the cerebellum, how is the corpus callosum, how is the cavum septum pellucidum, how is the spine as well. So complete neurosonogram is the first thing that I will ask for or do, and I'll go for an infection screen also for her because infection is one of the most important cause which may lead to ventriculomegaly. I would go through her all the previous reports, whether a screening was done, serum screening was done for her or not. How was the anomaly scan? Were the ventricles or a higher side that time? Were they prominent? How were the images of the spine then? And then I would formulate some plan for her next. Definitely MRI plays a good role over here because at 32 weeks, I will have good findings in MRI as well. But my neurosonogram forms the base of it first. So if you
as
have any
said,
neurosonogram
Smita,
findings for her,
we
I
did
would
a
like to see them.
sonogram. Yes. So her cerebellum was normal. It's a teardrop shaped ventricle. CSP is missing. And also, if you see the mid-sag TVS, when we did an extended neurosonogram, corpus callosum is completely absent. And also,
So
when
we
we
did
test sulcations, also there were lots
they were
of
less.
sulcations.
They're less. So neurosonogram gives us lot many
So we made a
information
diagnosis
as
of.
compared to MRI.
Yes. So actually MRI will give us some information, but the kind of scans that we do and with the transvaginal ultrasound and extended neurosonogram, we almost can pick up almost everything that we have. So now, Smita, the obstetrician has sent to you, and this is the patient who's crying and saying what can be done about it. So we have made a diagnosis on ultrasound. Will you do an amniocentesis now, or will you let the baby deliver and evaluate after birth? As madam said that we can't do a termination. Or in this era of medical board, should I do an
Yes.
amniocentesis even
Yeah,
at
that's
this
a very
30 weeks?
important point. That's a very important point. At 33 weeks also, I will go for amniocentesis. I'll first set up a genetic counseling also for this couple so that they get to know what could be the genetic conditions which are associated with such a finding. I'll go for amniocentesis. I'll go for investigation in that. And once I have a report which says that the baby is having some genetic issue as well as these findings where the baby will definitely have a very bad prognosis. So then I can go to the board and ask for a request for a termination for this baby. When we have the laws open for us, we can definitely make use of it. So I'll go for amniocentesis and further evaluation.
Correct. So, and Dr. Aditi, Dr. Smita, as a fetal medicine expert, has said that we'll do an amniocentesis. So, what will you counsel the patient about the prognosis now that we know there is an agenesis of corpus callosum, the sulcation is bad, there is, listen carefully along with this, and the MRI also showed the same things. So, will you also tell the patient, yes, it needs a genetic evaluation? Dr.
Yes, ma'am,
Aditi,
because isolated corpus callosum, obviously
do
we
you
should
want
set an
to do an
appointment.
amniocentesis at this
Ma'am, amniocentesis to rule out
moment?
other causes of ventriculomegaly. Some infection, CMV or toxo might be there associated. Though in this case, it is seen to be associated with corpus agenesis of corpus callosum. So because it is not an isolated corpus callosum find, we have to tell the patient ki there might be a good prognosis in either, in some patients they might be mentally retarded, but we have to set a counseling, as ma'am said earlier, with the genetic specialist, so that the patient should know all the pros and cons of continuing with the pregnancy. And I would advise her, I will have a proper counseling and tell her that we cannot guarantee her this child a normal mental outcome, basically. So at this time, and with the genetic counseling and everything, I don't think at 33 weeks we have much time for, because the results come very much later. But that is how I'll counsel her.
There is a corpus
Actually, ma'am, I was
aegis
very
will
bad.
listen carefully, and 30 weeks. So yes, Smita said amnio to be done. So amnio has been done. So what all will you send for, Smita, when you're doing this? One, you said torch, but
Yes, definitely. And then microarray is one thing that I would ask for. I'll ask for a microarray. I'll ask for an infection screen as well in that.
Yes. If you look at newer studies, one microarray will pick up about 6% over a karyotype abnormalities, and whole exome will also pick up much more, 27%. So here first we send for a microarray, and as we suspected there'll be something in the microarray, there was a 17p deletion, a Miller-Decker Leschen-Kefli syndrome. So, madam, we could get the report because this around 30, 32 weeks, we got a report by 35, 36 weeks. So now, Dr. Smita, patient has come back to you with this genetic report, and she says, what can I do? I don't want to have this child, and I don't know what to do about it.
So here now lies which is the place you are practicing. So if you are already into a medical college, you have the board with you. But like the people who are there in the private practice, definitely they will need the help of medical college because the boards are over there. I'll write a summary report with all the investigation reports that I have, and I'll refer this patient to the medical board seeking for the termination, because definitely this baby has got a very poor prognosis in the further life. Just a second. And with the board we can put all these findings and request them that this baby, if the couple wants a termination, they should be given a permission for that. And definitely the question that comes back to us is the baby will be live at 36 weeks. So we can always go for an intracardiac KCL and then deliver the baby. That is the thing that we can suggest. So if the couple is not comfortable with this child, we can help them out because we have a definitive diagnosis for it.
So why I brought up this difficult cases, because there is a possibility of medical board, there is a possibility of doing testing at this moment of time. And yes, we can solve this if this is completely high chance of having mental retardation. So if the parents don't want, even at 36 weeks, a medical board allowed us for termination. And because it was a live baby, first KCL had to be given, and then the baby was delivered full term 3 kg plus baby, but a termination was allowed by the medical board. So yes, the things have changed. Anomalies, if we pick up even late, can be managed also. And in addition, if I want to know the recurrence, Dr. Smita, what will I counsel these parents? We've done a
Definitely,
microarray for both of them. The parents.
Parental, yes. Parental studies are required to know where could have been the issue. So, do we have that report as well with us?
These two are both normal for both the parents.
So then this could have been a one-off case for the couple. So definitely, but then in next pregnancy, I would suggest them that give them a timeline. That NT scan, anomaly scan, they are to be done even at the growth scans, as we all do, that we see the heart, brain, spine, everything in a very great detail. So that keeping this in mind, if we could pick up things earlier, not as late as 30 to 33 weeks. So we will definitely keep a close watch in our next pregnancy as well.
Yes, so because the microarray is normal, the recurrence is going to be less, but it will be slightly more than the general population. So as you said, Dr. Smita, she needs to be followed up in her next pregnancy closely. And so she did follow up with us and had a new next child, which was normal. So we go on to our next case. The learning from this is that when you see ventriculomegaly, look for more other things also. Look for associated abnormalities and also in other system involvement, because they will have a bad prognosis. And especially some of these disorders, the diagnosis is very late after 24 weeks when the MTP act is already over. So mostly the ones like corpus callosal agenesis and cortical developmental malformation, diagnosis is very late, and so we may sometime have to go through medical board. So with this, I go on to our next case. And for this, Dr. Anjana, Kirti, and Dr. Sujit as our expert, whenever we are in trouble, we will go through. So Dr. Anjana and Kirti, madam, you are with us for this case. So, Dr. Anjana, how common do you see these clefts in your obstetric practice? Dr. Anjana or Kirti can take it, Dr. Kirti.
Ma'am, previously clefts
can
has
see
been
you.
common, but
Dr. Kirti?
there is hello.
Yeah,
Hello.
Dr. Kirti is there, madam. She's answering.
Ma'am, previously cleft palate were a bit common, but
Yes.
recently I think the incidence is declining.
So actually, if you go by the studies, India has got 35,000 children per year. Amount of 700 live births, one child will have a cleft lip. But actually, we don't say it so often as what is given in literature. But yes, they can be there. And by our mid-trimester guidelines, lip and palate has to be seen in all our anomaly scan. So we go on to one case in which it was diagnosed at the time of our anomaly scan and was correctly managed. So you have here, and I think Sujit, you can take us through this scan if you want to. Sujit? So here we have got a cleft lip that I see, and there was no palate. The palate looks completely normal. So it is only a unilateral cleft lip. Previous child had died of a bilateral cleft lip and palate. So this second pregnancy, she has come to us and she's got a cleft lip diagnosed, and she also had a high risk for trisomy 21 on dual marker, and NIPT was low risk. So, madam, how will you take it, Dr. Kirti? You have a diagnosis of cleft lip only, no palate, and no other associated abnormality, and her NIPT is low risk.
Ma'am, although she has a bad obstetric history, but
Dr. Anjana.
Hello. Hello.
Yeah, Kirti, we can hear. We can hear you.
Ma'am, although she has a bad obstetric history, but unilateral, hello, ma'am, unilateral cleft lip, we will go for an NIPT shows low risk, then we can go for with the pregnancy. After all, it's surgically, it can be corrected surgically after birth.
Yes. So unilateral cleft lip is usually a disorder which has got a good prognosis. Here, because the previous child had a cleft lip palate and baby had died post delivery, there might be a role of doing an amniocentesis, although her NIPT was low risk. So this patient came to us at around 26 weeks, and she had already said that we want to continue pregnancy. And so there is a chance of chromosomal abnormality in 1 to 2% and lots of syndromes also. So if we find a bilateral or median cleft lip or palate, then definitely amniocentesis is required. But here, because it was only unilateral cleft lip, but there was a history of a cleft lip palate and baby had died, so an amniocentesis was done, which was perfectly normal. So now, as you said correctly, that if we have this, it's a good prognosis patient, and so we allowed this pregnancy to continue. But we did do an amniocentesis, which was normal for microarray. Now, can I now tell her everything that she's completely fine, or do we need to follow her up in the antenatal period? And do we want to get a pediatrician involved in this, and or a surgeon involved already in the antenatal period?
Ma'am, you have to counsel her regarding the
Dr.
involvement of
Kirti,
pediatrician.
Dr.
Hello. Ma'am, in this case, the
yes.
patient should be counseled regarding the involvement of pediatrician, the need of an ICU stay for feeding purpose, and the need to involve a pediatric surgeon for cleft lip management. So it's better to have one consultation from them also.
Yes. So it is better to have this kind of a consultation prior to delivery, because the parents will be ready for what is going to happen with this. Is Dr. Sujit with us? Dr. Sujit?
Madam Sujit has left.
So anyone else? Dr. Smita, you can.
Yes, definitely. Whenever we find such kind of situation, as the
So
amniocentesis
Dr.
is required,
Smita, can you
and since I will definitely have a report of amniocentesis with me, because the previous child also had the similar problem.
Yes.
So more
So this,
that why this recurrence has happened. Now it's all sorted out that the amnio result is good enough. We are continuing the pregnancy, but yes, monitoring is required because there are certain anomalies which come later in the later gestation age. So once an anomaly is diagnosed, we look for others. We keep that thing in track so that other developing, evolving anomalies are not missed. And definitely a consultation and a opinion from pediatric surgeon is important so that the family knows that what will be done once the baby is born, what all difficulties they might have, and how will they be dealt, how will the baby look after the surgery. So once they go through all this counseling session in an antenatal period, they are much at relief that okay, this is a problem which can be dealt easily, and they will have stepwise plan with them, so that puts them at ease. So definitely a consultation at antenatal period is very important, and will continue the pregnancy till term, and then deliver whichever way goes, normal or cesarean, whichever way.
so we don't need to do a cesarean section for a cleft lip if it can be
No,
delivered
no.
normally.
If she
And at
delivers
full
normally,
coverage.
it's a normal
So we will
delivery. Yeah.
have the ready. So yes, the counseling is very important in these cases, and this has to be done before, because if the parents don't know about this diagnosis, then when the baby is born with such kind of a cleft lip, they'll be a devastated parents that this cut was there and you could not diagnose. And plus you have the team already who is going to help them in the feeding and the surgeries later on. So yes, diagnosis of cleft lip palate is very important. And if we have diagnosed and genetically normal, you can continue and it's a correctable disorder. So we go on to our third case of abdomen. We finished head and face and now on the abdomen. And for this, Dr. Anuradha, Dr. Geetika, and maybe Dr. Smita, you're back whenever we need your help. So Dr. Anuradha, we have this diagnosis made, but it required a lot of management later on. So this is a primary gravida, 18 weeks. Stomach bubble was not seen but looked very small. What else do I want to look at to make a diagnosis? So Dr. Anuradha or Geetika can take it.
And the first thing, if we don't see
Anyone
a
is
stomach
there?
bubble,
Dr.
we have to see for
Geetika.
associated polyamnios, because if we are, and firstly we have to examine, see the patient for at least 20 to 30 minutes for the to confirm that the stomach bubble is not visible, and probably another in 1 or 2 sittings. But finally, if we don't see the stomach bubble, we have to see for associated things like polyamnios or a blind esophageal pouch, which can be indicative of tracheoesophageal fistula, which comes as a most probable diagnosis if we don't see a stomach bubble.
So when so Dr. Monica has said, take a case of a non-visualized stomach. So I put in this kind of a table. If we don't see a stomach, then you look at the liquor. As you said, no, Polly, if it is there, then there is some obstruction, or the stomach is in abnormal position like a CDH or heterotaxy, or it is not able to swallow because of lip palate or even retrognathia. But most common cause is an esophageal atresia or a T fistula. If it is a increased liquor, if it is absent liquor, maybe PROM, FGR, renal agenesis, no liquor. That is why the stomach is not seen. So when you see no liquor, or is the liquor inside? And you also said to look at this esophageal pouch. So what is this esophageal pouch? Is this, you see that baby is swallowing, and then you can see that esophagus is getting dilated there, and that is the esophageal pouch, and the pharyngeal pouch above that. So these two markers are telling us that there is probably a tracheoesophageal fistula or an esophageal atresia. So Dr. Smita, what is the next step now that we made a diagnosis? She's 18 weeks. What do you want to do?
Now, since it
Dr.
seems to
Smita.
be that esophageal pouch is there, the esophagus pouch is seen, I think that it's a tracheoesophageal fistula. Stomach bubble is also not there. So we'll have to tell the family that, see, this is the abnormality that I am suspecting, because fistulas, what kind of fistula is it? We can't tell them on antenatal scan in 100% way. So we have to draw a diagram and tell them, give a visual kind of a picture that these might be the possibilities, and that's the reason I'm not seeing the stomach bubble over here. Any other abnormality seen, so it was not there in the case. We might find in later, as I said in the previous case also, so we'll keep a watch on that. Here also, I need to have a amnio to clear my chromosomes, that are they all normal or not, because why a abnormality has come in a baby. So I'll go with a amniocentesis and a microarray just to prove that if it is normal, then I'll continue with the pregnancy and I can guide the family. And here also similarly a consultation with a pediatric surgeon
So again,
so that
yes.
they have the idea about further next plans or course of management of the pregnancy and the fetus.
Yes, so T fistula is again associated with chromosomal, and yes, we need a multidisciplinary counseling because this is correctable, but it may be patient wants to continue or not continue, but it's a correctable disorder. Going to a pediatric surgeon, get them on the same page so that they are ready with whatever surgery will be required. And yes, what you said, it can be some new disorder may come up in the further time. So
Subsequent scan.
yes, she wanted to continue, and I'm back with you, Dr. Anuradha or Dr. Geetika. She's become 30 weeks and there's severe polyhydramnios. The AFI is 31. She is very uncomfortable. What can I do, and what is anticipated with this TE fistulas? Dr. Geetika.
Ma'am, if she has so much of polyamnios, there is a high likely chance that she will go for a preterm labor, or and plus the maternal discomfort associated. So we can advise her for amnio reduction, ma'am. We can reduce we can take some amount of liquor and relieve her of her discomfort, and put her on antibiotics, put her on a tocolysis, give her betnesol steroids, because we are expecting that she might have preterm delivery in the nearing course, betnesol course. And likewise, we'll monitor the pregnancy every 2 weeks.
So definitely yes, because there was an obstruction. It starts very early. It forms poly a lot, and so there will be discomfort and the risk of preterm. So as you said, correct, steroid to be given, amnio reduction was done, but we plan to deliver her as near as term as possible because she will require a surgery postnatally. So because we were able to diagnose this early, we could have team ready, and especially there was the feeding tube did not go inside. You don't do a bag and mask in such cases. Early evaluation, and so they could be operated upon. So there was a T fistula, and that was anastomosis, and the baby did well. So we go on to our fourth case. We have got time. Yes. So disorder in which the diagnosis was made, but it suddenly worsened. So did that mid-trimester scan showed us some things, but it worsened. So for this, I have Dr. Neha, Dr. Narhari, and maybe Smita, you're between. So we go on to a renal case. We know kidneys, we assess always. We look at the pelvic dilatation, and then we also look at the bladder as well as the renal vessels. So our AP diameter cutoff is 4 millimeter in the second trimester and 7 millimeter in the third trimester. But we always follow this UTD classification to find out what level of obstruction or what level of dilatation there is. So there is a UTD for less than 28 weeks and more than 28 weeks. 4 to 7 is significant and 7 to 10 for 28 weeks. So now with this background, I have this patient, 32 years old, G2A1. 29 weeks she has come to us from Dubai in view of hydronephrosis and dilated urethra and bladder. So if we went back and looked at her scan, NT was normal, anomaly scan, there was bilateral hydronephrosis, but we looked at the images, the pelvic testis was 6 millimeter, no, normal cortex ureter not dilated, bladder not. So it is like a UTD-A1 at 20 weeks. So Dr. Neha, Narhari, any one of you, at this week at 20 weeks, when I see 6 millimeter, are you worried much? What will you tell the parents? Will it resolve? Will it increase? Dr. Narhari can take it.
Dr. Narhari has now joined, madam. Kirti is there. Geetika is there. Kirti, Geetika.
Monica, anyone can take.
Monica Pathak, madam, has not come.
Anyone can take this.
Yeah.
Hello. Yes, ma'am.
Yeah, please.
Ma'am, six.
Kirti. So,
Ma'am, at
so at
6 mm,
20
I
weeks,
want you.
6 millimeter pelvic test is.
Ma'am, since rest
Sorry?
everything are normal, I won't be worried for 6 mm. Hello.
We can hear you.
So it falls into UTD-1.
Yes, ma'am. But she
So
is
it
on
is a
GD.
mild form of pelvic testis. So maybe we are going to follow her up and not alarm her too much. But yes, it will still need to be followed up. So Smita, when will you call her back for a scan after
I'll
this
call her within a
20
month. Her
weeks?
next growth scan at
So
by
yeah.
24 weeks, I will call her and I'll see. Or if she is not able to come, or if the protocol of the institute is after anomaly scan, they see at 28 weeks. So that would be the time. But I'll see, like it's written over here, male fetus, she had maybe had this diagnosis at Dubai and they were told. But whenever I find any
Yes.
pelvis towards on a higher side, I definitely put more intention to see what is the gender of the baby, because male fetuses, yes, definitely the pelvis might be on a little higher side. And then I'll keep more close watch for other diagnoses which a male fetus can have, though I can't reveal, but I'll keep it to myself and keep a watch on this baby.
Good
So
evening,
here,
ma'am.
then, if it is a male fetus, I'll call at 24 weeks.
Yeah, so this patient. So this was all in Dubai, and she's come at 29 weeks to us for the first time. And with this kind of a pelvic testis, the bladder is significantly distended, the urethra is dilated, the kidneys are both dilated, and it is like A23 with blunted calyces and normal Leica and Doppler. So now, Dr. Kirti, if she comes to you as an obstetrician, what will you guide her now? She is very angry that why was this not told to us? Why it was said that these are okay, it will not have any problems.
Hello.
Anyone?
Yes, good
Good
evening,
evening.
ma'am. I'm
Yes.
I'm back. I'm sorry I had to leave in between. Ma'am, patient is
Yeah, you can-
obviously he would be angry because whenever anything happens
Yeah,
to
Dr. Neha,
the
you
child,
also,
parents are having a lot of concern and issues, and it is natural for them to worry. but we can counsel them that it is a correctable problem, and we don't need to terminate the baby for this thing. Post delivery, we can get a surgical connection done of the baby.
So yes, also tell them that the kidneys have got significant pelvic LCL dilatation and it is a PU valve. So our dilemmas were, do we deliver her now? She's 29, 30 weeks. Or do
No,
we
no, ma'am.
wait till term, but the kidneys are going to become bad? And do I do an fetal intervention, put in a shunt at this moment of time? She's 29, 30 weeks. She actually came for a shunt to us. So, Smita, how will you counsel her? She's 29 plus 4 weeks, 1.5 kg baby.
Definitely, termination is not required in such a case, not even premature delivery, because why to give the brunt of prematurity to a baby which can have a very good prognosis later on? We are all worried for the kidneys. So, yes, we are definitely going to monitor this baby till we see the corticomedullary differentiation of the kidneys is maintained. There is no need to worry about it. And if the center is there which can do any kind of fetal intervention, putting a shunt into the amniotic fluid so that the bladder is drained and the back pressure to the kidneys is released. That is what we want, that the back pressure of the urine should not go on the renal cortices and damage the pelvis and everything. So if shunt facility is available, expert is there, they can go for such a thing because it's 29 week and few days right now. We still have a long way to go. But keeping an eye on kidneys and then the availability of the intervention that can be done. And if a center is there which can vulgarate this posterior urethral valve, then nothing like it. We can go ahead with that procedure.
We must at
So
least try
she
to
had come
continue
to
the
us only for
pregnancy
that
till
shunt
34
only, but because she's almost 29 plus 4 weeks, we can. So that is what, because if she was 26 weeks, we would have put in a shunt, but because she was almost 29, 30 weeks, the LICA was good enough. So shunt is only placed when there is no other option available. And at 29, 30 weeks, we decided we will monitor, as you said, we'll monitor a little as much as possible. And as what Dr. Neha said, we will pull on till 34 is what our target was, maybe a little more if possible. But at 34, if you see, the LICA had completely become very less. The kidneys cortex had become thinned out, echogenic but not dysplastic. There were no cysts, but there was echogenic cortex. And because the LICA was less, we decided to deliver this patient now. So this is the baby, 2.5 kg. LSCS was done, previous section was there. And the pediatric surgery team was ready and they did a fulguration of the PU valves. And this was a reflux in one of the kidney. The baby did well and they went home to Dubai with the baby. So yes, again here a diagnosis which we started off thinking that it is not so bad. It was just a pelvectasis of 6 millimeter, can suddenly turn around and the patient can get angry with things. So a mid-trimester scan should never be called as everything is normal. You have to tell them that whatever we can see is at the moment normal, but any evolving abnormalities can be there later on. But yes, if we do find things like this, then we can still manage such in institutes where you have got the surgery plus the NICU availability for such cases, and sometimes fetal medicine procedures can be done. So last case of us, a disorder where nothing was seen at our 20-week scan and then late diagnosed case. So this our last case. Again, a mid-trimester scan was done somewhere else. 38 years old, non-consanguineous, 1 neonatal death, 1 MTP, 1 ectopic, and 1 child alive. Previous 2 LSCS. So this patient came to us with an outside NT normal. Anomaly scan was normal at 19 weeks. You can see the BPD, HC, AC, and the FL is also 26 centile. Perfectly normal looking anomaly scan. And then they did their scan at 30 weeks where all the long bones became short. You can see the femur is significantly less than the first centile. All long bones are short. So now anyone can take it, whoever is here. Palak, I think, has not spoken, and I remember Palak, I gave her a prize for that RH ISO immunization. If you are there, Palak,
Yes,
what
ma'am.
will you counsel? What do you think the baby will have?
Good evening, ma'am. Firstly, this is a case of of skeletal dysplasia. The patient has already got an NT scan and a TIFA, that is a level 2 scan, which shows normal bone structure. However, this scan at 30 weeks is showing the long bones, which are less than the first centile. So, any of this should point and raise a suspicion of skeletal dysplasia and severe FGR. Severe FGR is less likely because it clearly shows isolated long bone shortening. So we should go back and look at the second trimester, that is the level 2 scan, and check whether the biometry was done properly. Then we should look at the causes of skeletal dysplasia, maybe the etiology, like a genetic cause we can find out from the family history, or if there is an isolated chromosomal anomaly, or if it is due to, say, an endocrine disorder that is running in the family. Teratogens are less likely because it is an isolated shortening. So we should rule out all these genetic causes and chromosomal anomalies for this. At 30 weeks, like we've discussed in our previous cases, we should find out whether it is a lethal anomaly or a non-lethal
So,
anomaly. Because, yeah. For a lethal anomaly, because for termination, we would probably be requiring, requiring a medical board and a proper channel for it. A non-lethal anomaly, however, can be properly investigated and the cause can be treated.
So yes, Palak. So do we have Nidhi or Dr. Arun? They've not spoken. So Dr. Nidhi? Okay. So as what Palak said, that we need to look at etiology. The first one is whether it's a growth restricted baby. But for that, we would have an AC, which is less. Here, the abdominal circumference is normal. Second, it could be Downs also. Trisomy 21 can also cause this short, long bones, especially the femur and the humerus, if they are. So you go back and look at the screening. And final possibility is that all bones are small and it is a skeletal dysplasia. So we did scan her, and you can see the head circumference is on the higher side. The AC is normal and the femur is short and all the long bones are short. If you look at the graph also, for all of them, one second, yes. So you can see all the long bones are short and the head is higher up. So it is a macrocephaly with the short bones. So Dr.
Vanda
Smita,
madam,
you are back with me.
Vanda
How do
madam,
you
your
counsel her?
network
What
is
test
poor.
will you do?
Vanda madam, your network is breaking between.
Hello?
Your network is poor, madam. Vanda ma'am, your voice is breaking in between.
Sorry.
A little bit.
Better now? I'll keep everyone. Better now?
Better, madam.
Better.
So the head is on the bigger size and the bones are all smaller size and the Dopplers were normal. So we are thinking it to be a skeletal dysplasia. So Dr. Smita, you're back with me. What do we
Yes.
do?
So for this mother also, I need to have what kind of skeletal dysplasia this might be. So I need few more findings for the scan, that how is the femur foot ratio, then how is the thorax, what is the shape of the thorax, how are the ribs, so that I can try to identify the kind of skeletal dysplasia as much as on scan, whether it is lethal or non-lethal. How are the clavicles? How is the scapula? So the scan needs to be very thorough, whatever be the gestation age. So that will be one point I'll redo. I'll see all the long bones measurements on both the sides for all the upper limb and the lower limb and take out all the ratios. And definitely, how is the thorax? That is very important. And apart from that, any other abnormality, like how is the heart, how is the brain inside. So, thorough examination of the fetus is required. And definitely, then I go over to my needle test and try to find out what kind of skeletal dysplasia is this, so that I put a name to it, a label to it. And then I'll send that sample for skeletal dysplasia panel or a whole exome. But panel usually gives us the kind of final diagnosis that we are looking for and try to find the genes for it so that we can further evaluate the family. That who is the
So
carrier
as you
of such
said,
a gene.
Smita, we looked at the baby. So there is a frontal bossing which was seen. The femur foot length was less. The TCSC ratio was normal, so it was non-lethal skeletal dysplasia. And also there were no fractures, and the skull bones were normal and the ribs were all okay. So we gave a diagnosis of non-lethal skeletal dysplasia, probably chondrodysplasia. Achondroplasia is what we thought of. And so, yes, as you said, we send for an amnio, but here it is important to send for a whole exome for this patient
Whole
because
exome.
skeletal will usually present with the single gene disorders more. And also there is an angle which we see in the femur, and if this
Femur,
diaphyseal metaphyseal angle is increased, like here it is 134,
134.
again a marker for achondroplasia. So we were almost sure it is achondroplasia. And the report also came out as FGFR, which is an autosomal dominant disorder. And so this is now diagnosed and pinned on to be achondroplasia. So can we ask medical board for termination for these non-lethal skeletal disorders? Dr. Smita.
What does the parent want?
Or anyone can
That
take
is
it. Anybody
private.
senior.
I
No,
would
the
ask for
parent
the
wants
parent's choice.
termination. Can the medical board give for non-lethal skeletal? Here on the program is the senior people here, maybe anyone can take it for this non-lethal skeletal dysplasia. It is just a short, long bones. Do we allow them, or can it should be the patient's decision to take? Dr. Asha Jain, are you there? Joined in?
Yes, yes, yes.
So
I've been
anyway,
here for a long time.
Smita,
Good evening, ma'am.
your saying is that you can.
I would ask the parents that what is their
Good evening,
choice, what
Asha
do they
ma'am.
want, because
Namaste.
they have to raise the child. They have to take through the complete life, their life and the child's life.
There is a newspaper article today itself ki whether the ethics of the child lies with the parents or not. And the Supreme Court has again said, yes, it is on the parents to decide on the child. So Asha ma'am, what do you think?
Obviously, it is the parents who have to decide.
So then we actually, because they wanted to terminate, this was almost 36 weeks she has reached. She went to medical board and the medical board refused on grounds of non-lethality. So they said, because it is non-lethal, it is something that you should continue. Why are you trying to cause death for your child and all that? Then they went to High Court and the High Court gave them permission to do termination for a non-lethal abnormality. This came in the newspaper also for non-lethal abnormality at 36 weeks. Previous to LACS, they allowed termination and so feticide, and then actually cesarean had to be done because it was a full-term baby which had to be delivered. So,
but you know, personally, I think this is not such a good idea.
Yeah, but that is what the parents want. It is not
That is
us
what
to
means
make a
it's not
decision.
for us to make the decision.
Yes,
It's the parents who have to make the
parents'
decision.
choice.
Yes. And they came back to us with this report, and this is an autosomal dominant. So the parents' sampling has been sent, and we've told them most of the time it is de novo and may not happen again. And so they are coming back to us with a whole exome report. So this was the last controversial case I brought about because a non-lethal anomaly can we terminate these cases as well. So I think I will stop here. Thank you, Dr. Smita, for all the expert
Thank you so much.
and all the other obstetricians who were with me throughout. These are very difficult cases, and I understand that it is better to just know what all can come up and what all we can do about it. So thank you, Monica, for calling us here and getting us all together. And I actually thought how to get simple cases, but I always get these difficult cases. I can't help it.
You are known for it, ma'am. I must say, you have a Bhanuvati ka pitara for wonderful cases. I must say that. It was so good to be with you on this panel.
And
So
it's
good.
always good to discuss. It is
And all
nice.
that, all the difficult cases going to madam for the secondary
Yes.
and tertiary opinions. So we can imagine, madam, it set my brain also, I had to have a cup of coffee in between to set my brain, So it was, they
I
were.
just enjoyed this. I just enjoyed being with Madam on the panel. Thank you.
Thank you.
Madam, thank you so much. And we will definitely approach you later for some simpler topics, which can more number of people. But my panelists did a fantastic job. I mean, I must give full marks to Dr. Neha, Kirti, Geetika, even Aditi, and Palak. They answered you, ma'am, nicely and confidently. So that should be
Dr. Monica, you should give me full marks that I asked you to call Vandana ma'am.
So we were discussing in the the usual time I call Asha ma'am is around 7:15 or 7:30 a.m. when she's in the kitchen and I'm walking my dog. So madam, I asked madam karna kya hai? What to do? And after one synergy, I'm blank for 2 days. I don't know what to do next. And then slowly the ideas come. So my go-to person is Asha ma'am whenever I want to do an ultrasound or fetal medicine thing. And after that, I said, I need a moderator. So the second madam's suggestion was Vandana ma'am, and Vandana ma'am is also very dear to me. So I thought it's the best combination possible for all of us. And we are
Vandana
so.
ma'am, are you going to be here to listen to my lecture?
Yes,
I
definitely.
hope not. You are so big that
No,
I'm
no,
going to be
I want.
terrified presenting
No,
in front of you.
No,
Don't
you do
you're
that.
terrified of Asha
I'm
ma'am.
going to sit here to listen to it and revise my theory back again.
Okay.
So,
Yes.
another word about Asha ma'am. Asha ma'am is the boldest person I know. I mean, to whatever be the authorities or anybody, if madam feels something is wrong, she will speak out. She will speak out confidently. So, Asha ma'am, I think that is because of the Aquarian trait you have got, the intelligent and the fearless Aquarian she is. So now let us,
And grounded. And she's
grounded.
grounded.
Thank
Yes.
you so much.
But I get a lot of scolding from her also.
Chalo shuru karo jaldi. I have to be on another one in some time.
Anna madam, thank you so much. And Purva, are you there to start the session?
Yes,
Second
ma'am.
session?
Yes.
Thank you.
So moving to our awaited second session, that is the correct approach to the mid-trimester scan. To chair the session, we invite Dr. Jitendra Kumar Panda, sir. Sir is past President Bhubaneswar OBGY Society. We welcome you, sir. We have with us Dr. Sanjeev R. Nayak, sir. Sir is presently President of Bhubaneswar OBGY Society. We have with us Dr. Sangeeta Sharma, madam. Madam is presently President of Bilaspur OBGY Society. We welcome you, ma'am. We have with us Dr. Archana Chauhan, madam. Madam is presently President Bilai Durg OBGY Society. We welcome you, ma'am. We have with us Dr. Tribhuvan Sahu, sir. Sir is presently President of Raigarh OBGY Society. We welcome you, sir. We have with us Dr. Ashok Kumar Padi, sir. Sir is presently Secretary of Association of Obstetric and Gynecologists of Odisha. We welcome you, sir. We have with us Dr. Tapasi Pati, madam. Madam is presently Secretary Bhubaneswar OBGY Society. We welcome you, ma'am. We have with us Dr. Basant Kumar Pati, sir. Sir is presently President of Khordha OBGY Society. We welcome you, sir. We have with us Dr. Ujaswini Patel, madam. Madam is presently President of Burla OBGY Society. Welcome you, ma'am. We have with us Dr. Leena Baru, madam. Madam is presently Secretary of Burla OBGY Society. We welcome you, ma'am. We have with us Dr. Sanghamitra Mahapatra, madam. Madam is presently President of Barampur OBGY Society. We welcome you, ma'am. We have with us Dr. Indira Palu, madam. Madam is presently Secretary of Barampur OBGY Society. We welcome you, ma'am. We have with us Dr. Sudha Rani Pradhan, madam. Madam is presently President of Rourkela OBGY Society. We welcome you, ma'am. We have with us Dr. Sujata Kumari, madam. Madam is presently Secretary of Rourkela OBGY Society. We welcome you, ma'am. We have with us Dr. Anup Kumar Ghosh, sir. Sir is presently President of North Odisha OBGY Society, Balasore, Odisha. He is a retired Additional Director of Health and Family Welfare, Odisha, and has a more than 4 decades of working experience in OBGY. Now I hand over the session to our chairperson to introduce our speaker, none other than Dr. Asha Jain, madam.
Dr. Jitendra sir is there since the very beginning. Dr. Jitendra sir, would you like to do the honors? Jiten Kumar sir, are you there? Ji sir.
Yes, I am here. I am here. Good evening. Good evening. This is Dr. Jitendra Kumar Panda,
Good evening.
the outgoing president of the Bhubaneswar Gynec Society, and the incoming one is Sanjeev Naik. I hope he is here. And our secretary, Tapasi Pati, they all seem to be here. Anyway, first of all, I have to give a big thanks to Dr. Monica Singh for selecting us as me as a chairperson in this very useful webinar. And she has nicely selected this 29th episode of Synergy on the 29th day of April. This is a very nice coincidence. And all I can say that I have got a great appreciation for Monica Singh for her endeavor for synergizing all the societies together to hold this webinar. I have heard a lot of adulations from the very reputable people and gynecologists in this seminar. So I have nothing more to add other than to say that we have got a full support for you, Monica Madam, on your next election. We wish you a big success, and I, on behalf of Bhubaneswar Society, have a full support for you.
Thank you, sir.
And
Thank you so much.
Now I can come to Dr. Asha Jain. I know her very well because she once shouted upon me, Dr. Jain, you did once shouted upon me because I did not, that was before your next election, because I didn't pick up your phone, neither I phone you back. But you are such a upright person. You are such a straightforward person. You did ask me, Dr. Panda, why didn't you answer my phone? I was very ashamed. I was a bit flabbergasted. I know you are a very, very upright and straightforward person. I really admire you for that. Well, I all know you as a FOGSI chairperson of Food and Drug Medical and Surgical Committee of FOGSI in year 2026. I know you have got a big biodata here, and you are director of SMSA Hospital. That's probably your hospital in
Sir,
Raipur.
I think you can leave rest of it, sir. What you told about me is enough.
No, madam, I have to speak. I have to still enjoy reading your biodata. If you want me. Well, all I can say, you are a president of Raipur Menopause Society, and you're chairperson of the FOGSI FDA MSc, as I have already told, and you are, I know that you have a lot of good curriculum, you have a lot of good interests, and you are not only a good academician, you are a good clinician and a good organizer as well. We have listened to your many webinars over the years, and thank you, madam. I can all say that we are really grateful for your deliberation in this webinar. Thank you very much. You can carry on.
Thank you so much, sir. Monica?
Yes, ma'am.
How much time do you give me?
Ma'am, you have 1 hour complete. You can finish earlier also, but we have 60 minutes for you, ma'am.
No, it's not that. The question is, Vandana ma'am has already taken you through across a lot of things. So, you want details or should I just skip through?
No, ma'am, I want the basics.
So, namaskar. And at the outset, I want to thank Dr. Panda sir for that very succinct introduction that he gave, and Dr. Monica for having me on this program and making me read up 3 different papers on the 20+2 approach, then the normal and abnormal anatomy, and then the guidelines. So that is the flow that we are going to follow. And I know all of you are not doing your sonographies. If you're doing them, you're not doing the mid-trimester anomaly scan. But even if you're not doing the scan, you need to know what constitutes a correct scan. Because if the scan is not correctly done, if the sections are not correct, and you only read the report, then what you see in the report is not actually the truth. So you need to understand what are normal planes, what is a normal scan, what should be part of the report. As you've seen, Vandana ma'am has demonstrated so many reports. So there are certain things that have to be part of the report. So I pray to Ganeshji, Sri Ganeshaya Namah, that he'll light up the mind and we will be able to absorb what I'm going to talk about. So I have been given the topic, the correct approach to mid-trimester fetal ultrasound. So here I will be taking you through what is the correct approach, but please look at it from your own perspective. You get the report, what are the images that are must have in that report. If those images are not there, it is an incomplete scan. If something is incomplete, does not mean it is normal. So we will be going through that one by one. So in the ISWAG basic training, there is a 20 planes approach to the routine mid-trimester scan. Now this is what I have taken this first part of the slides from, and it's the standard of ultrasound. So what are the key questions? What is the rationale behind this 2 overview and 20 planes approach? What are these planes? And how do these planes relate to the ISWAG basic training recommendations? Why are they actually basic? And when you're doing this scan correctly, which abnormality should be excluded? This is, what is the rationale? It gives you a structured and logical method of examining the mid-trimester fetus. So you assess the fetal size, and then you also assess the anatomy. So in the fetal size, you take the biparietal diameter, the head circumference, the abdominal circumference, and the femur length. In the second trimester, sometimes you may have to leave out the BPD when the shape of the head is not very normal, but head circumference has to be included. You need to include the Hadlock method of calculation. And then you have to, when you take your probe across all the 2 overviews and 20 planes, you will have excluded 50 fetal abnormal appearances. So what are these going to be? What are these planes? There are 2 overview sweeps and 20 planes, which are divided into 7 anatomical areas of the fetus. Each plane relates to a specific fetal section. Measurements to be taken are included. Each plane has a number of structures that have to be evaluated. You see the BPD, but whether it is the correct BPD has to be decided by what is included in that section. When you have to refer the case to a higher center, that is also there. And then this combination will make you able to diagnose 50 abnormal things. So what is the overview 1? The overview 1 or the sweep 1 is the longitudinal sweep across the baby, the head and body. Basically, you take your probe and run it over the fetal body to find out where is the head, where is the breech, which is left, which is right. So that is your sweep 1. And whether the fetus is alive, what is its relation to the placenta, what is the status of liquor. This is the initial thing that you're going to look at, because we have to remember that this overview 1 is very, very important, because it tells you where in the uterus the baby is located. All these sections are not relative to the uterus. They are relative to the fetus. It is only the first one where you first find the head and then follow the spine and have a complete orientation. So the first 3 sections are the spine. The next 3 are the head. Next 4 are the thorax, which includes the heart. So you have a sagittal and coronal section of the spine and body separately. Then in the head, you have the transventricular, transthalamic, and transcerebellar. And in the thorax, you have the lungs and 4-chamber view, LVOT, RVOT, crossover, and the 3-vessel trachea view. We think this is echocardiography. No, it is not. These are parts of a basic mid-trimester scan. Many sonologists will write, echocardiography is not part of the scan, and they would just do the fetal heart and see nothing else. Doesn't work. These 4 sections are part of the basic scan. Then you have 3 sections in the abdomen, which is the transverse section of the abdomen with stomach and umbilical vein, where you take the abdominal circumference. Then the TS at the cord insertion, and then a transverse section with left kidney and pelvis, right kidney and pelvis. In the pelvis, you have the transverse section of the pelvis, bladder, both umbilical arteries. Then you have the limbs. You measure the femur, and then you should be able to demonstrate 3 bones of both legs, both feet in normal relationship, and 3 bones of both arms, both hands, and normal relationship. Now we even see the outstretched hand like this. We also see the foot. Then the face. Face, you see the coronal view of the upper lip, nose, and nostrils, which Dr. Vanna just showed you when she was demonstrating the cleft lip. Both orbits, both lenses in the orbits, and then the median facial profile. Then you go to the overview 2, which is the transverse sweep. You remember in the first sweep, we had gone longitudinally. In the second, it is a transverse sweep from neck to the sacrum, 1 vertebra at a time. So if there is any spina bifida, if there is any neural tube defect, you will be able to detect it. This is something each one of us should have on our table. These are the sections that have to be given to us when we have the reports. Can you see this? It has everything. What are the sections and what is the normal report? The radius, ulna, these are the basic reports these are the images you need on the report. What are the abnormalities that can be excluded? Now you come to requirements from each plane. When you go to the sweep 1, you see the fetal heart and skull, where they are, right, left, whatever. Section 1 is the sagittal spine. In ultrasound, sagittal means longitudinal. 2 ossification centers of each vertebra. You would classically see a railroad sign. Transventricular plane. We will demonstrate all these one by one. So this you can see. The first sweep will tell you what is the situation of the baby. It's a breech. It's a vertex with the back to the right. This is a breech with the back to the left. This is a vertex with the back to the left. This is transverse, back on top. You could also have a transverse with back below. So this is, and you have a beating heart. You know where the baby is. This is the first orientation. You would be able to determine the fetal lie and presentation, cardiac activity, what is the number of fetuses inside, whether it's a twin, whether it's a monochorionic or multiple pregnancy, where is the placenta, how much of fluid, and you can also have the biometric measurements. Now the first, how are you going to place your probe? How are you going to place your probe? This is a patient, this is her head end, this is her pubic symphysis. So the first probe is placed on her abdomen transversely. This is the way you're going to take the first, where is the head? This is what you're going to do. You are going to rock it up and down and see what is happening. So you rock it, you see where the position is, and then you can measure. So this is the plane where you go across the baby. You go across the baby. Plane 1 is sagittal complete spine with the skin covering. You will have a railroad appearance of the spine. From there, you turn at an angle of 90 degrees and you get a coronal complete spine. Go lower and you have a coronal complete body. Then in the brain, you have the transventricular, transthalamic, and transcerebellar. This has moved a little, but this is the transthalamic, this is the transventricular, and this would be the transcerebral. So then you move through plane 7 to 10. You have all the heart, 6 to 8. Then go further down. You get the three vessel trachea view. Then you have the transverse view of the abdomen. So first is what you're going to see, the abdomen with stomach and portal vein where you take the AC. Come a little down, you'll see the cord insertion. Come further down and you will see the kidneys and pelvis. And then come further down, you'll see the bladder. We will take you through these sections. In plane 15 to 17, you see the bones. So you will be able to see the hand and the radius ulna and the femur and tibiofibula. You will also see this angle. In no section should both these bones and this footprint be together. So you can see all bones and you can see their relation. Then you have the 18, 19, 20, which are the facial planes. So you have the coronal view, lips, nose, and nostrils. Here you have both orbits and lenses, and then you have the profile, the same view where you get the NT. What are the 50 that you're going to exclude? In the spine, in sweep 1, you would exclude 1, spine miss 6, head 8, thorax 16, abdomen 8, pelvis 3, limbs 3, face 5, and sweep 2, you would be exclude everything. So initially, if there is an intrauterine death or there is an anencephaly, you would miss it. Then CTG लगा दीजिए. In the spine, you would have an abnormal abdominal situs. If there is a diaphragmatic hernia, if there is a meningocele, open spina bifida, sacral agenesis, sacrococcygeal teratoma. In the head, a lobar holoprosencephaly, banana-shaped cerebellum, cystic hygroma, large posterior fossa cyst. So you have this entire list which you can see. So what are you going to do? If you find anything abnormal, please refer for a second opinion. So working through these 2 overview planes and 20 planes in the prescribed sequence is logical and time efficient, and the whole baby can be examined. You need to examine the fetal anatomy correctly. You should be able to distinguish normal and abnormal appearance, and anything that you cannot confirm as normal should go for a further opinion. So now we are going to talk about the next paper, which is normal and abnormal. So what are we going to exclude? We've already seen. So we will now talk about one by one. What is the normal appearance and what is the abnormal? So first, this is the fetal position and situs overview. Now there are two simple methods. One is this thumb method, which I find very confusing. What you can do is you can mentally place yourself in the position of the baby and find out which side is the heart, which side is the head, and then you can locate which is the left side or right side. Like this baby, if the mother's pelvis is here, then you will find that this baby has the back to the left of the mother. Therefore, what comes near the probe is the left side. What is away from the probe is the right side. Now, if it were reverse, then what comes on top would be the right side. So this is what you locate with yourself. This thumb position is something they tell you. I find it a little difficult. Fetal position and situs. So you have seen this. This is the baby. You have seen the abdomen and you have located that this is the spine and this is the stomach. You go back and look at the heart one by one. And if the stomach and the heart are on the same side, you draw a straight line and the apex of the heart is to the side on which there is the stomach. That means, and this is on the left of the fetus. Then this is situs solitus. So one thing is, before you do anything, in the first sweep, you should know which is left, which is right. If you don't know which is left and which is right, you are in for a problem. You will keep making mistakes and sometimes there is dextrocardia. The whole, everything has turned left to right. And then you will think because they are on the same side, it's not abnormal. It's not like that. Now, in the head circumference section, what are you going to see? This is the transventricular. You see the midline falx cerebri. You see the cavum septum pellucidum. Now, this cavum septum pellucidum, intact as a rectangle, is a must see in all three sections. If you don't see this section, there is something wrong with your adjustment or the fetus. So in all three sections, you should be able to see it. Dr. Vannaja showed you a case of corpus callosum. And here, this ventricle was very wide like a teardrop. That is when the corpus callosum is absent. So cavum septum pellucidum has to be there. Front is narrower than the posterior part. There's a regular contour. This lateral ventricle at the level of this posterior fold, it has to be less than 10 mm and the anterior horn has to be slit-like. In case of corpus callosum deficiency, it is like a bull's horn. That you would not see here. They are quite thin. So this is a normal section. What about the posterior? You have the cavum septum pellucidum, you have the cerebellum, you have the vermis in the middle, which is hyperechoic. You have the thalamus, and you can see these folds that you see. These should be seen. What are you ruling out by these? Anencephaly, the skull is complete. If there is a lemon-shaped skull, if the ventricles are big, this is normal, and this is lemon-shaped skull, this is large ventricles. So this can be diagnosed in this single head examination. If you have a neural tube defect, what do you see? You see this normal railroad appearance, two parallel in the spine, this is normal. But in abnormal, There's a break in the middle. However much you adjust it, you're not able to see it completely. Then here you have the lateral ventricle less than 10. This is huge. It's huge. Then this is the nasal fold. This is the CM. Here you can see this cerebellum. This is dumbbell shaped with, and here it is banana shaped. So this is the lemon sign. This is the banana sign. This is this. In plane 2, you will see the defect. Here, can you see? It's not going right through the middle. This is the defect that you see. So now we come to the thorax, the heart. Supposed to be the most difficult thing, but if you know the basics, first thing is know which is left, which is right. Then locate the spine, keep the heart anterior. Then draw a line from the spine to the center of the chest. 2/3 of the heart should be on the left side. This area should be 1/3 of the area of the chest. If you take a circumference, it should be half that of the chest. And there should be the aorta anterior to the spine to the left. The descending aorta, the chamber next to it is the left atrium, then the left ventricle, and right atrium. Then you would see in detail is different thing, but there's this vessel and the inferior vena cava is on the right side. And on the left, there is a single vessel in a normal case. So you have right ventricle is most anterior, below the sternum. Left one makes the apex. You have the tricuspid valve, which is lower, closer to the apex. Therefore, there is a difference. There is what we call offset. This is the mitral valve, this is the tricuspid valve, and there is an angle in between. This is because of the septum primum and this clear 4-chamber view with both ventricles and both atrium equal on both sides, the foramen ovale opening on the left side, a moderator band on the left atrium, and this offset or the crux is seen. So this is a normal heart that should be seen, and the stomach, the liver, nothing should be here. On this plane, you can also see both the lungs. What are the abnormal appearances? So there is no offset here. Here there are 2 vessels on the left side. Here the aorta is overriding the septum. These can be seen easily in the 4-chamber view itself. So this is a very basic view that we all should be able to see. Then in the abdominal section, this is where you measure 1 rib on either side for the heart and for the abdominal circumference. This is the spine and descending aorta. You have the stomach and you have the umbilical vein. The portal sinus should be curving away from the stomach. So it should be a very smiley type of thing, because if this is on the other side, it is a sign of an abnormal ductus venosus. So you will measure, it should be circular, there should be no pressure on the abdomen, because if you pressure, this flattens out. What are the abnormal appearances? This is the duodenal atresia. Dr. Vandana told you, you may not be able to see. You may not be able to see it, the stomach at all, where you have to follow it again. You have to follow it again and see. And then this is hydrops. What you see, so much of fluid between the skin and the abdominal contents. So there is If there is ascites, that baby is already in trouble. Then you have the cord insertion, and you should be able to see the 3-vessel cord. When you are taking the abdominal section, you have to remember the kidneys should not be seen in this. If the kidneys are visible, it is a sign of a incorrect section, or for some reason your kidneys are not correctly placed. So what do you see in a cord insertion? This is a normal cord insertion. You can see an omphalocele, or you can have gastroschisis. So this is omphalocele is an abnormal cord insertion where the cord inserts into the apex of the defect. It may contain the liver, bowel, and it is covered by a membrane. Whereas gastroschisis is below and to the right of the cord insertion. So the cord insertion is normal, and this is below and to the right. It contains only bowel, which is free floating. It is not covered by membrane, and by this simple cord insertion section, we are able to see this. What about the kidneys? This Vanna ma'am has just shown you that you take a transverse view completely, you measure the pelvis and see how much is it. 3 mm is what we usually would see. And if it is large, then what can happen is what you have seen. So the kidneys are lateral to the spine, posterior to the stomach, and the renal tissue is similar in echogenicity to the bowel and liver. If you take a coronal view, it's easier to compare. And the cortex has a homogeneous echo pattern, and it should be less than 7 mm. First trimester is 3, and even at 9 months, it should not be more than 7 mm. This is the bladder. The bladder is central position in the fetal pelvis. It is thin-walled. There's no internal content. And the baby has a 30-minute cycle, so the size may vary. If you are doing a scan over an hour, you should be able to see that it's emptied once and filled again. And it has an umbilical artery on each side. What are the abnormalities? A single umbilical artery, which is associated with a lot of things. Then Vanna ma'am already showed you the abnormalities. So you have a dilated renal pelvis. You have a megacystis where the bladder has gone right up to the chest wall. This is a dilated bladder and both ureters. These are all images that she's already shown you. So all these can be excluded. Luto can be excluded by doing this properly. We have also seen this case of femur length, which has to be correctly measured. The angle has to be seen. It should be parallel, cover 2/3 of your screen. Spurs should not be included. And what are you going to see? 0 to 15 degrees should be the angle. There should be shadowing behind it if the mineralization is correct. If there is no shadowing, again, it tells of a problem. And this is the upper and lower limbs. So the number of bones, the length of the femur, visual assessment of others, I usually measure at least one set of bones, the shape, the position, the movement, flexion, and extension. Why is that important? If the baby keeps the limbs in one position only and the limbs don't move, it could be a sign of arthrogryposis. Okay? Then we come to the face. This you have seen the clefting, different size of the orbits, retrognathia. So these are these things that you can see. If there is congenital cataract, that also you will be able to see. So there is such a thing as size and relative size. A small head circumference could be microcephaly, spina bifida. Spina bifida is something that should be detected early. It should not be left for the mid-trimester anomaly scan, but at least it should be detected in the mid-trimester anomaly scan. Microcephaly is an evolving anomaly and may not be seen at 20 weeks. You keep on following, and that is what you see. A small AC could be because of a congenital diaphragmatic hernia, which you have not actually seen. There could be an abdominal wall defect or early FGR. A small femur, skeletal dysplasia, Down syndrome, or FGR. But if there is FGR, everything will be smaller. Then we come to the amniotic fluid volume. So these days, the FMF, Fetal Medicine Foundation, advocates going only for the depressed vertical pocket, and it should be between 2 to 8 centimeters. AFI, where all 4 quadrants are measured and added, is usually not done. What is important is that the patient is lying flat. The probe should be parallel to the ground. It should not be angulated. If it is angulated, if it is tilted, your reading is wrong. You need to look through the whole abdomen skirt and find out which is the largest pocket. And from that pocket, you measure vertically, put a Doppler, see that there are no vessels in there. There should be nothing contained in this area where you are measuring. And when you measure, if there is too much of water, it could be anencephaly, upper GI anomalies, as Dr. Vandana just showed, tracheoesophageal fistula, skeletal dysplasias involving a small chest. And then oligohydramnios and hydramnios could be because of renal anomalies. Again, these are only visible after 16 weeks. They cannot be detected earlier than that. Fetal growth restriction and premature rupture of membranes for any cause. Now, these are all the images that we've already seen. And if it were a live session, I would have asked which is normal and which is abnormal. But these are very basic things. Holoprosencephaly, this is normal. This is the lemon. This is this is normal. This is an abnormal spine. So this is holoprosencephaly.
Madam, first is normal, this one.
Yeah, the first one is normal. There's a mix, na? So we have to understand what is normal and what is normal at different gestations, because the baby is growing regularly. The kidneys, the brain are structures that keep growing till the baby is born, and the brain continues to grow even after that. Therefore, they have to be looked at in every trimester. You have to have a consistent and logical approach, and don't scan randomly. And if you're not able to confirm the appearance or size, seek a more experienced opinion, but don't give a report without actually saying that this is normal or abnormal. Now, what are the guidelines? These guidelines have come up in 2022, and they tell you that screening examination for fetal structural anomalies should be done. There should be, this scan is also a baseline for fetal growth assessment. It includes the viability, number, dating, anatomy, placenta, and amniotic fluid. Not all anomalies are detectable at 18 to 24 weeks. Some anomalies evolve later, and the detection depends on operator skill and equipment. So what do? You first have to counsel the patient. This is the most important part. Even when you're referring your patient for a scan, she should be counseled, because mother will always ask, family will ask, "Sab theek hai?" You can tell them 10 problems and they'll still say, "But sab theek hai." Here you have to understand that you cannot guarantee normalcy in spite of a normal scan. So you have to explain the purpose, the benefits, and the limitations. This is a guideline. It has been included. You have to discuss the possibility of missed anomalies, and you have to also tell them how referral is going to happen if there is an abnormality. So what are the components? Cardiac activity, fetal number, chorionicity. If it is multiple, gestational age, biometry, anatomical survey, placental location and appearance, and amniotic fluid. You remember in the mid-trimester anomaly scan, we have not looked at the placental location, but the guidelines say that you have to do that. The MTAS also does not include the amount of amniotic fluid, which has now come in the guidelines. You also have to look at the uterus and adnexa. And if you find fibroids or cysts, you have to mention them in the report. Should be done between 18 to 24 weeks. This is a good practice point. Optimal visualization of anatomy with adequate fluid should be there. Only then you have a correct decision. Who gets it? Everybody. That is a grade B recommendation. Every pregnant woman should get it. Even if the first trimester is fine, still they should get it. For the operator, the recommendation should be that the person doing it should be trained. This is a good practice point. That person should be in regular practice, should be updating their knowledge, and audit should be there of their findings. And if there is any abnormality, then the referral pathway should be there. Equipment should be use an appropriate ultrasound equipment. 2 to 9 megahertz probe should be used. It should have freeze calipers, image storage, which should be reproducible in the future, and color Doppler is desirable. Again, Dopplers are not part of the second trimester scan unless you find an abnormality. Ultrasound safety, follow the ALARA principle. That means as low as reasonably accessible. Minimize exposure, limit the Doppler, and just for photos, keepsake imaging, please do not do a scan. About incomplete examination, the recommendation is repeat or refer if visualization is incomplete, grade C recommendation. Do not label non-visualized structures as normal and document the reason, maternal habitus, fetal position, or fluid. That is part of your report. Biometry is mandatory. The recommendation is measure the BPD, HC, AC, and female length. This is a good practice point. You need to store the image for each measurement and use consistent reference charts. So these are the images that I've already shown you. These are the reference standard biometry images, the thalamus, the cavum septum, and no cerebellum should be there in that field. Recommendation, you use the Hadlock, which works good enough. It has stable estimate across ranges, and use baseline for growth surveillance. You cannot change the EDD each time depending on the size. Whatever is your earliest scan, which is a dating scan, that is the date against which you calibrate all your other reports. So the size, the recommendation for growth is recommend size as centile or Z-score. Write which chart has been used. Do not change EDD if earlier dating exists. And if there are discordant parameters, different parameters showing different centiles, it requires investigation. If there is FGR, use the Delphi 2016 criteria. Low AC or estimated fetal weight centiles, then do Dopplers and check for maternal disease as well. Refer for a detailed assessment. Amniotic fluid, use DVP for oligohydramnios, AFI for polyhydramnios. This is a grade C recommendation. Also record subjective assessment and state the method in the report. What have you used? This I've already told, that measure largest vertical pocket, less than 2 centimeters oligo, 2 to 8 normal, more than 8 poly. Probe should be perpendicular to the abdomen. For AFI, sum of 4 quadrant vertical pockets. In each pocket, there should be no cord or parts. AFI may overdiagnose oligohydramnios. This is the limitation. Therefore, for oligo, use DVP. For poly, use AFI. You can see the membranes. Amnion and chorion should be fused at 16 weeks. Differentiate benign amniotic sheets from bands. And if you see any suspicious bands, you should mention them. You also have to see fetal movement, because if there is transient absence of movement, it is not abnormal, but you should be able to see. Biophysical profile is not part of this scan. If there is persistent abnormal posture or reduced movement, then that child requires, a fetus requires further evaluation. Umbilical cord insertion has to be seen. It is a good practice point. You have to mention where it is placed: central, paracentral, marginal, velamentous. And velamentous is associated with FGR and vasa previa, therefore reporting is required. You also have to write the number of vessels: single umbilical artery or double normal 3-vessel cord. You have to avoid undue anxiety in case there is a single umbilical vessel. Rule out associated anomalies, and FGR is possible. You have to evaluate completely. If you see one problem anywhere, you have to evaluate the complete fetus point by point, as I have shown you before. Routine pulse Doppler is not recommended in low risk. That is a grade C recommendation. But for heart and cord identification, it can be used selectively. Chorionicity should be diagnosed in the first trimester. Assess the placenta lambda T sign and record amniocity. So here is the monochorionic, where you have the T sign, and then you have the dichorionic, where you have the twin peak or the lambda sign. But this should ideally be done in the first trimester. If it is not done, if it is uncertain chorionicity, manage as monochorionic. This is a good practice point. Label the fetuses by position and refer high-risk follow-up. For the skull, assess size, shape, integrity, density. This is a good practice point. Oval contour, continuous echogenic ring, and exclude defects and abnormal shapes. If there is poor mineralization of the skull, you usually see the posterior ventricle, and you have to angulate to see the anterior ventricle. But if you can see both, the skull is almost transparent. That is osteogenesis imperfecta or hypophosphatasia, and this has to be investigated. If there is herniation, there could be encephalocele. So use all 3 planes and assess the contents of each correctly. CSP, Fox, thalami, cerebellum, cisterna magna. In the second trimester, you can also see these folds where the brain has started to fold, and these should be seen. First, they are flat, then they get deeper, and then they become like a T. This is the evaluation, and this you should be able to see when you see the head. For the thorax, assess thoracic shape, lungs, diaphragm. Mediastinal shift, cardiac screening, the axis, situs, rhythm. This has to be seen. The recommendation is 4-chamber, outflow, 3-vessel trachea view. The chamber symmetry, intact septum, AV valve offset has to be seen. Outflow, RVOT, LVOT, I've already shown you. 3VT views. This will detect the arch and conotruncal anomaly. So these are the 5 views now they are recommending. If you remember, in the 20+2, they had taken only 3. 1, 2, and 3. These were the 3 views. Now they have taken all 5 in the guideline. So you have to take all 5 views. the 4-chamber view, the LVOT, the RVOT, the 3-vessel view, and the 3-vessel trachea view, which is a little higher. You see the ductal and the aortic arch. Abdominal situs and stomach. Stomach on the left, normal size. Absent or persistent, right, small, right-sided. In the upper abdomen, you should be able to see the stomach umbilical vein and a gallbladder. You have to rule out heterotaxy or vascular anomalies. So if the stomach is on the right side, if the liver is occupying the whole upper abdomen, depends. If there is an AVSD, this you should be able to make out. Cord insertion, we've already seen this. Document abnormal fluid or echogenic bowel. The bowel is called echogenic when it is as echoic as bone. If there is ascites or if there are dilated loops, this has to be referred. Kidneys, we've already seen. You have to visualize both kidneys and bladder. Renal pelvis and bladder size. If enlarged, you have to perform a detailed assessment. Renal pelvis equal to or more than 7, follow-up. Bladder at the 95th centile, if the wall is thick. Then more than 14 mm at 18 weeks, 23 mm at 22 weeks. Persistent megacystis, this has to be follow-up. Spine, alignment has to be seen. The skin on top has to be continuous. So there should be a bit of fluid over the spine when you're assessing, otherwise you will not be able to make out. And associated cranial signs with neural tube defect. Always if you see one thing abnormal, you see a lemon-shaped skull or you see the banana spine in the skull, you have to look and search the whole spine to find if there's any defect. So this is a normal image that you should be having. These 4 are in the chart that you should have. Limbs is the same. Symmetry, length, shape, and alignment and movement. Digit counting is not required. So this is the same thing. Genitalia we don't do, but we have to see. We cannot report, but we have to see. Placental location is included now. You have to assess the relation to the internal os. If it is a very thick placenta, you have to measure that. Transabdominal first. If it is a low placenta, do a transvaginal. You have to report the site, appearance, and also look for placenta accreta. If there is signs of accreta, again, you have to see. Now, there is a recommendation. If the edge is 15 mm from the internal os on transvaginal, you have to follow up. And at 32 weeks, you make the final assessment. This is grade C recommendation. When you say many migrate away in 3rd trimester, it means that the placenta grows more in the area where there is a better blood supply, and therefore usually it grows upwards, and in that case the lower end may become free. If there is a suspicion of placenta accreta, means you don't see a clear hypoechoic line beyond the placenta and the uterine wall, then do a detailed evaluation, take the history, and look for lacunae and interface disruption. So this is how you're going to measure the cervix. This also is now included, and then you have to report. So, and if you are advising a test, then you have to see that all this is reported. The patient ID, date, indication, EDD, number, viability, presentation, placenta, amniotic fluid, biometry, anatomy checklist, the limitations, and the impression. So reporting has to be as per protocol. You have to mention the charts used. And if it is incomplete, document non-visualized structure and the reason why it was not visualized. You have to repeat the test or refer. Please do not label as normal if it is not seen. So systematic planes plus accurate measurement should be there. There should be an active exclusion of abnormalities, and there should be a clear documentation and referral pathway. So adhere to defined planes and landmarks for each measurement, use correct caliper placement, validated charts, report centiles and z-scores, and the method used, and also document the images, and if there are any limitations, write those limitations as well. Don't be afraid to refer for a second opinion. Thank you so much.
Thank you, Madam. Jiten sir, your comments? Sir, please unmute.
Well, all I can say that, well, I am not an ultrasoundologist. So what I have listened to her, and it's a very, very informative talk she has given as usual. And I can say that she's a very good teacher. All the talk she has given has been really eye-opening for me. I must thank you, Dr. Asha. Please come again and again and give us talks like this. Thank you so much.
Thank you, sir.
Thank you, Asha ma'am. And in fact, one of your points was that you have to continuously update yourself. So for mediocre sonologists like us, I think we have to keep updating by watching webinars and watching you speak on this platform. But I would really appreciate if you could really give us some videos of doing the scan, taking us through sweeps. If you make
Actually, the thing is, it doesn't work.
But simulators assisted.
Simulators, they have pre-loaded software. So
Yeah.
for a beginner, simulators are okay. The basic thing is, most of you are doing laparoscopy, I think.
Yes. So I think
most of you are doing laparoscopy. What happens is you develop the habit of eye-hand coordination. Your hands are working here and you're looking somewhere else. Right? Similarly, your brain has to understand that the baby is inside the uterus in a particular position, and you have to look at the screen, and your hand, you need to practice and practice and practice. Your hand should move relative to the baby and not relative to the uterus. That is the basic thing. Now, if I demonstrate, I'm moving it on the abdomen. That is what you're looking at. The mental image of where that baby is inside can only come when you have that probe in your hand.
No, ma'am. What I was saying was, if you could understand what I'm trying to say, we don't want to see your probe movement on the fetal abdomen. While you're taking the same talk, your mobile camera with a stand is focused on your screen. So when you're speaking in a flow that I am moving my probe, this is the 4-chamber view. Now I rotate, this is RVOT, this is LVOT, this is 3-vessel view, and this is 3-vessel trachea view. So in one...
Your hand is moving reverse, you go up, up.
No, madam, I'm just making an expression. So what is like basically in that 15 or 20-second clip,
that is not so hard to learn. The basic thing is to get a section and to have it in your head, what are the contents of that section? Because something looks like it and you're very happy, you got it. But what are the contents of that section? I have been doing an NT scan, I don't know how many times, but I go back and I listen. I do the MTAS and I again go back and read. Because somewhere when you are used to, you miss points. Most important is if you know what is the content, if you know your anatomy, then you're going to get the section. Even in a first trimester scan, you're able to get all the sections with a little movement of your wrist. You get everything.
So that is it, Asha ma'am. When I used to do the best scanning, when I used to read lot of anatomy during COVID time, I did all
And
our
brains are expert at forgetting.
Yes.
So whatever we are doing today is what we are going to remember. What we did 20 days back is 20 days back. Like we don't remember what we ate 20 days back.
So it's a good idea to keep charts in your sonography room, like you said.
I have
with the
I have
20
them
days.
stuck on my behind my machine. You know, all my charts, my checklists are stuck right there.
Similarly, like if I do an anomaly scan, madam, I do the checklist of all the, the points I have to report. And if
But
you
what
don't,
you see is when I see reports coming, most of the time, the images that are provided are not big enough. The sections that are provided are not as described by ISWA.
yes, ma'am. So, ma'am, Asha, ma'am, that's what I'm saying. I think we have got a point over there that the theory lectures that we are hearing, it's reiterated whatever we need to do, but still a person,
What you are talking about is a workshop.
it's a
It's a
workshop.
live workshop,
But
which
ma'am,
can happen.
Ma'am, live workshop with PCPNDT is very difficult. How will so many people collect at Raipur or Bhopal or Mumbai? It's like a one-on-one training. You have to go for it. That is why, ma'am, these people have to leave their practice and go for weeks and months at a fetal medicine center. So sometimes it is not possible. Maybe there will be a way out. I think Jiten sir is there, and so many youngsters are there. There will be a way out in the future where the weekend training or something can be arranged. So thank you so much, Asha ma'am, for that delightful lecture as always. Vandana ma'am's panel has been extraordinary. And at the end of
Vandana ma'am?
Yes,
Vandana ma'am?
I'm here.
Yeah.
I
So
was listening to your debate between Monica and you, Asha ma'am.
madam, we always have a debate like this.
What you want, what exactly you want is let there be two days of programs on basic biometry, one on Doppler, one only on NT for 2 days, which can be done mostly not online, but it can still be done in medical colleges because their PCP-NDT won't have a problem.
See,
We've done
right
it
now,
in-
Society of Fetal Medicine, Raipur, has done a Doppler workshop. Dr. Vinita was here. She's here. So she did it in AIMS, and they had more than 100 delegates over there. It was on Doppler, and it was full day, and it was like grand. Dr. Vinita, you want to say something?
Yes, ma'am. Vinita, ma'am, welcome. Ma'am, please, आइए program में. We would like to listen to you. Vinita, ma'am, are you there?
Yeah, I'm there. I'm there. Can you hear me?
Yes, ma'am.
Yes,
we
yes.
can.
Just a minute.
We can.
Can you hear me?
Yes, ma'am. Yes, ma'am.
So it was like it was a grand program, and I wanted just 50 registrations, but to my surprise, I had 100 registrations, so I had to split into 2 days. So I had to split into 2 days. It was completely hands-on live demonstration on so many patients, and we then we one day we did for our PGs and a few PGs from AIMS Nagpur and from other medical colleges, and next day we did for all Raipur Obstetrics Gynec Society, and I had to stop Bhilai Society and Bilaspur Society to register because I told ki I won't be able to manage so many people, so next I would be doing in Bhilai followed by in Bilaspur. So this was my vision always, that at least every obstetrician should know how to do growth Doppler, at least to start with. Then we'll have NTNB in future, NTNB certification course as preached by SFM and FMF India. So in due course, time, we'll be having all those certification workshops, and let's see how it goes. But it was a wonderful experience for me.
Yes, madam. So, ma'am, actually, there are so many youngsters who really want to learn from stalwarts and from teachers. But the same thing, like you have to make a program wherein you can learn different things or have a comprehensive 6 months sort of training, which is sometimes difficult. So, Vinita, ma'am, we would like to have you in our program in the near future. And
Yes, sir.
so much for giving us permission to collaborate with SFM Chhattisgarh chapter, ma'am.
Yeah.
Thank you
It's
so
a pleasure for me also, ma'am, and I wanted to make a announcement also. Like I in association with the SFM Chhattisgarh, in association with SFM Madhya Pradesh, we'll be doing annual conference together. So this
Oh.
is this we already had fixed up. Just we need to fix up a date that to maybe end of this year or next year, early next year. So this date is not finalized, but definitely we are doing it together, either in Bhopal or Indore or Raipur. Matlab, most probably it's in Bhopal. So definitely we'll be meeting and we'll be collaborating. So this is like we want to make all obstetricians become part of fetal medicine and get trained in ultrasonography, which is very important.
Yes, thank you. Thank you so much, Vinita ma'am. That is wonderful news. And now, just like I think are some of our faculties who could not join earlier and come to the program. Tripti is there, and Dr. Archana Chauhan is there, and Geetika Sharma is there. Would you like to Tribhuvan sir is there? Would you like to unmute and say bye-bye before we close? Any of you who would like to join the
Yes, Dr. Monica ji, thank you so much. And really, you did wonders for the Foxy. And as Dr. Munjal said, your smile is contagious as well as your knowledge is also contagious. Thank you so much for everything.
Yeah, I've not done anything. I've just coordinated, and that is why I just sit back and relax, and everybody is teaching over here.
No, it's all your hard work. You did a lot of hard work for this symposium.
Monica, I
Ji.
have to be on another
Yes,
webinar.
ma'am.
Can you
Yes,
allow me to go?
thank you so much, ma'am.
Thank
So,
you, Vinita. Thank you, Vanna ma'am, for being
Yes,
there for
yes,
me.
yes.
Thank you so much.
Yes, yes.
And thank you, all the respected audience.
thank you, ma'am. Good night, ma'am.
Thank you, ma'am.
Our next Synergy webinar is scheduled in May. We are yet to decide the dates because some of our team members are going on summer vacation. But we have a very interesting topic related to vaginal surgeries. So please stay tuned in. Dr. Purva will be giving us the program very soon, and we will be disclosing the dates of Synergy 30 very soon. So thank you so much, all dignitaries, and thank you to all my friends from Odisha, from Chhattisgarh, and from Uttar Pradesh who have joined this program today and made it a grand success. Thank you, Intas Pharma. Thank you, our medical advisor, Team Intas, Dr. Vishal Dave, who himself is a gynecologist, for giving us a wonderful show. Despite so many changes in the flyer, we could make it happen. And wish you all a very pleasant evening. And thank you so much.
Thank you.
Thank you.
Thank you,
Thank
Dr.
you very
Monica,
much.
and wish you all the best from our side. Thank you so very much,
Thank
ma'am.
you. Thank you.
Just
Thank you
a
very
last
much.
Thank you.
all
Thank you so much, ma'am.
last parting sentence. All presidents and secretaries of the various Foxy societies will get a link for e-nomination for Foxy election in the first week of May. Kindly do nominate my name for chairperson, Foxy Infertility Committee. I will be forever obliged to you. Thank you so much.